A very warm good morning to everyone. I'm glad to welcome you all for the second day of the national workshop. I hope that yesterday's sessions and workshop were highly fruitful for each one of us. So as we start on this new day, let us carry forward the same enthusiasm, energy, and actively participate in today's sessions. Once again, I welcome you all to the second day of the national workshop. So without much delay, let's begin with the sessions of the day. The first eminent speaker of the day is Dr. Nikhil Rani, thoracic surgeon from MGM Medical College Hospital, Navi Mumbai. He is a minimally invasive thoracic surgeon with specialized interest in robotic and video-assisted thoracoscopic surgery. He has completed his MBBS from MJ Medical College, Navi Mumbai, so he is a proud alumni of this same campus. He has completed his super specialty training in thoracic surgery from Medanta, the Med City in 2020, and also he has completed his specialty general surgery from Inlax and Budrani Hospital, Pune in 2010. He has a rich experience of 17 years as a thoracic surgeon, including 7 years experience in thoracic surgery. So his areas of expertise include robotic and video-assisted thoracoscopic surgery and keyhole sets chest surgery. I request Dr. Padmaja Dawale, Associate Professor, MGM New Bombay College of Nursing, to come on stage. And also I welcome Sir on stage and I request her to felicitate him.
Very good morning, all of you. I thank organizing team to inviting me on this prestigious forum of a national workshop on emergency and trauma management by nurse practitioner. I'm Dr. Nikhil. I'm a thoracic surgeon, so definitely I'll speak on thoracic surgery. Regarding financial disclosure, I have no conflict of interest. I added this statutory warning because I'm a thoracic surgeon, deal with tobacco a lot. So I do not promote any habit forming activities. It's just to understand the topic. Let's begin with the topic, chest trauma. Since yesterday, the trauma, I am not going in the definition straight away. The chest trauma incident and causes, it varies with the worldwide. It's different in different areas. The causes of the chest trauma is a road traffic accident, most man-made, firearm injuries, fall from a height, suffocation, poisoning, and other causes. Most of the 60% of the chest trauma are road traffic accident. And this chest trauma, it's like in mall we go buy one, get one free. The chest trauma is never. It's a severe injury. So it always associate in 7.5% have multiple injuries, and 70% always have either long bone fractures, closed head injuries, or abdominal injuries. The chest injuries patient, out of these 10%, these are the patients because the trauma is so high that they die on the spot. You cannot do anything for them. 5% die within 1 hour of reaching the hospital. I said 5% die within 1 hour of within reaching the hospital. So how important is your role to save these lives? 80 to 85% respond to basic resuscitation and the chest tube, and 5% of the patient requires emergency room thoracotomy. As all know, the function of the chest consists of heart, lungs. So heart pull the blood, in the lung it get oxygenated, and again heart push the blood. And this chest movement, during inspiration, chest expand, and expiration, it relaxes. So the negative pressure inside the chest maintain the pulling of the blood from the periphery, oxygenation, as well as the air entry into the chest, and then again mixing with the oxygenated blood, pushing towards the vital organs. So any disturbance in this homeostasis will lead to a abnormality, a deviation from the normal physiology, leading to the symptoms and signs. The trauma could be a penetrating, like in war, or gunshot injury, which is less common in this part of country, but which is more common in the northern part. The blunt injury, the trauma, blunt injury because of the road traffic accidents. The trauma include the symptoms, signs, clinical examination, investigation, and treatment. I'll be covering all these aspects. The symptoms, usually this chest trauma patient, they come most of the time, they are brought by the bystander or by relative, or rarely they come self. There is a history of road traffic accident, fall, trauma, and gunshot injuries. The chest pain is a pleuritic type. The pain in the chest, pleuritic means as the movement increases, the pain increases. When you inspire, when you expire, that time the pain increases and decreases. That is called pleuritic chest pain. That is pleurisy. There is a shortness of breath, palpitation, and the symptoms of associated injuries. The examination include this patient due to the insufficiency of oxygen or defeat, they have a sweating, accessory muscles of respiration like ala nasal, sternocleidomastoid muscles are active. Normally, when you see the ala nasal and the sternocleidomastoid doesn't take part in a respiration. When they are taking in part of respiration, that means there is a labored breathing. There is a tachypnea, respiratory rate more than 20, tachycardia, increased heart rate, blood pressure depending on either high blood loss or or just the injury that will lead to either hypotension or hypertension. Most of the time, chest injury patient has a hypotension because of the blood loss in the third space. The examination includes systemic examination, other system, and the respiratory system include upper respiratory tract as well as lower respiratory tract. In upper respiratory tract, ala nasal, accessory muscles of respiration, open mouth breathing. These are the signs indicate there is a severe dyspnea. In a lower respiratory examination, inspection, palpation, percussion, and auscultation. And in inspection, you can, normally, there is an equal movement of the chest wall on both the side. In the anterior aspect, supramammary, mammary, inframammary, axillary, upper and lower, and in the back, in between the scapula, interscapula and infrascapula, and in the scapula, supraspinatus and infraspinatus movements. These are normal and equal on the both sides. But when you find a deviation in this side, there's some side there's less moving, there's a pathology on the same side. Secondly, there is on auscultation, the air entry is reduced on the affected side. Normally, air entry is equal on the both sides. Since yesterday, trauma, I saw the previous talks were on ATLS, so I'll not go in detail with ATLS. Straight away moving to the chest trauma. So in a primary survey, and there is a secondary survey. In a primary survey, where the 5% of the patient going to die, we have to find out these conditions and treat them immediately. And these life-threatening conditions which are deal with primary survey are airway obstruction, tension pneumothorax, open pneumothorax with sucking chest wound. There is a wound on the chest and the atmospheric air goes in and causes pneumothorax, flail chest, massive hemothorax, blood loss, and the cardiac tamponade. We'll go airway obstruction and in the secondary survey, simple pneumothorax, hemothorax less than 1500 ml, pulmonary contusion, tracheobronchial injury, traumatic diaphragmatic injury, blunt esophageal trauma, myocardial contusion, and aortic disruption. So airway obstruction, yesterday, Dr. Ankita and Dr. Sathe madam has already spoke on this, so I'll not go in this. definitely you'll have to suck out the secretions and maintain the airway if require a tracheostomy. In case of open pneumothorax, normally the chest movements are because of the negative intrathoracic pressure. So when this negative intrathoracic pressure is breached, either the air from the lungs or air from the outside because of the open wound, causing lung to deflate. We'll go in detail, and that leads to an tension pneumothorax. So next is the flail chest. We'll go in detail in pneumothorax. So flail chest, when the ribs, there are 12 ribs this side, 12 ribs this side. So when the one rib fracture at two places, but the three ribs at the same time. So these portions, so that segment is moving paradoxally. If during inspiration it moves in, during expiration it moves out. So that is called as flail chest. I'll just show you on this video. You can see the movement of the chest, wavy chest. So when the ribs are fractured, right rib are fractured at two places, it is called as lateral flail. But sometimes it may occur right side one rib fracture and the left side same rib fractures. So moving the center, so central segment moves paradoxically. That is called as central flail. Have you noticed those movements? Yes. So the chest wall injury, the ribs and intercostal muscles is a chest wall, not the pectoralis major or fat. The chest wall is the ribs and the intercostal muscle. So these the ribs get fractured because of the direct injury or crush injury. The rib fracture is seldom life-threatening. It may lead to perforation of heart and blood vessels, other injuries, and this leads to pneumothorax. And associated with other injuries, it leads to pain and shortness of breath. Depending on the topographic location, when the first rib is fractured, there is a high likely that aorta, upper structure of the chest, aorta, tracheobronchial tree, or brachial plexus injury. When it is a mid ribs are, then the flail chest, or a lung injury, or a diaphragm. When there are lower rib fracture on the right side, there is a liver. So it could be associated with liver trauma, or on the left side, it is associated with the splenic trauma or a diaphragm. So when the ribs are fractured, the multiple fracture rib, so there is a pain, and that moment that ribs are not expanding properly. So hypoventilation leading to pulmonary compromise, atelectasis, and pneumonia. So similarly, sternal fracture because of blunt or penetrating trauma, same mechanism. So the treatment is good analgesia, oxygen support, chest physiotherapy, incentive spirometry, steam inhalation, and sometime intercostal block or epidural analysis. There is no strapping. Strapping is not required in fracture ribs. So when the lungs get injured, so the air from the lungs is coming out, or the blood vessel from the pulmonary circulation is coming out. So it may lead to either a pneumothorax or a hemothorax. So pneumothorax could be a simple, just a small amount, or open when there is open wound and outside air going in, leading to accumulation of air, or it is a just tension. I'll go in detail. So simple pneumothorax is most common, and the causes are lung penetration or central airway injury, esophageal injury, or herniation of abdominal viscera, or it could be because of external sucking wounds. Open pneumothorax seen in penetrating chest trauma or blunt chest trauma, sometimes postmortem. So open pneumothorax leads to ineffective ventilation, and that can be a fatal. So pneumothorax, the air accumulate within the pleural, between the visceral and parietal pleura, leading to lung collapse. This collapse lung lead to ineffective ventilation. This leads to respiratory and diaphragmatic ineffectiveness. This pushes the mediastinum to opposite side. When the mediastinum is pushed out to the opposite side, there is a kinking of the blood vessels, and that leads to reduced venous return. And there is a compression of ipsilateral lung, and this reduced venous return leads to severe, ultimately lead to severe venous reduction and sudden cardiorespiratory collapse. That's why this patient has to be treated immediately. A tension pneumothorax, when there is no open wound, but inside air is continue to accumulate because it is not getting pathway to come out. So it accumulate, and it's, you can see there is a black shadow. So air look black on images. So black shadow, this indicate a tension pneumothorax. If you diagnose tension pneumothorax on chest X-ray, If you diagnose pneumothorax on chest X-ray, that means you have not done complete examination, because there is no air entry, there is hyperresonance sounds. These are clinical examination. You should diagnose tension pneumothorax on clinically, so that the pneumothorax can be relieved. Either could be because of just putting a wide bore needle into second intercostal space, mid-clavicular line, or intercostal drainage tube. Tube is placed and placed into the chest, and it is connected to underwater seal, so that this air will come out. I'll explain this in detail further, and then treat the cause. Simple pneumothorax, just underwater ICD, or sometimes it doesn't require. Treat the cause: analgesia, antibiotic, chest physiotherapy, and incentive spirometer. Everywhere it is common in analgesia, incentive spirometer, chest physiotherapy. When there is a injury to the blood vessel or a lung, the blood comes from the blood vessel, leading to a blood accumulation of blood into the chest, leading to hemothorax. It could be because of fracture ribs, pulmonary laceration, that is tear, aortic rupture, heart injury, intercostal vessel injury, or major pulmonary artery injury. So this is the hemothorax. It's a effusion basically. It's a opaque shadow on the chest X-ray. So putting a chest tube, definitely ATLS has to be performed prior, and blood transfusion if needed. So intercostal drainage tube. So intercostal drainage tube is inserted in a triangle of safety. The triangle of safety is anterior border by pectoralis major, lateral border of pectoralis major, posterior border by the mid-axillary line, and the inferior border is horizontal line drawn along the nipple line. So this is the triangle of safety. You can see nipple line, horizontal line. This is your anterior axillary fold and the mid-axillary line. So local anesthesia is infiltrated, and the cut is made. And during the intercostal muscle, the dissection is done. You can just close your eyes, spread your fingers, and just feel. So you can see you can feel like a rib. And when you on the upper border of lower rib, where you puncture, because the nerve and artery traverse lower border of upper rib. So to enter, it should be upper border of lower ribs. And the chest tube is put and connected to underwater seal. So everybody uses toilet at home, either Western or Indian. Have you ever thought why there is a water in this toilet bowl? Have you thought of? So this, if there is no water, then it will be a directly connection with the sewerage, and that in that sewerage get decays due to bacteria and harmful microbial. They produces the toxic H2S, that is gases, CO2, methane, and ammonia. And if it is directly connected, these gases will come into our house and fill those gases, our house. So to block that, there is a trap, because the pressure in the gases is much higher than your room pressure. So that if you put a water, so these gases will not come out and it goes outside. So same way, the intercostal, and if this is the external view where the pipes are on downstream. If you make a loop of this, if it is like a loop of this, then there is a further fluid will not move downward. So there is a looping. Did you understand this? Why these are sloping and straight down? I'll explain why I added this slide. Secondly, everybody in our country, in northern part, there is a hookah habits. So they fill this hookah with a water bottom, and they immerse this hose into the water, and they say it should be 1 inch below the water level. If it is less than this level or more than this level, then the particulate matter is not filtrate, and you will have a ineffective hookahs. Did you understand? If the water level is more like this, so you require more pressure to inhale. Okay, and if it is less, then particulate matter get inhaled. Okay. So water level too high or below the downstem, it experience the problem. So ideally it should be 1 inch. So same way in a ICD, this is my ICD, 2 centimeter underneath, and you can see the chest. If you can see the lung movements. When the lung moves, it moves. That means this is a functional ICD. If you make a an outside view of that sewerage pipe, if you make a loop, the fluid will not flow. So how this fluid will flow, the further fluid? It's not flowing. Even in this, see, they're asking patient to take a breath. Still he is not able. So this has happened. The chest intrathoracic pressure is -2. To overcome this -2, this underwater we say 2 centimeter. If this underwater is increased more than 2 centimeter, or this in this column, you can see around 15 centimeter. So the chest require more than 17 centimeter of pressure, which is not feasible. So the further air or further fluid will not come out. Patient will find difficulty. So it should be a slanting, and this water lock should not be there. See, we are asking patient to cough, to generate, but the column is not moving. And that's why the further fluid or pneumothorax didn't get relieved and patient has continued to suffer. This is called fluid lock. And the initial was the looping of the fluid. Coming to the pulmonary contusion, there is a injury to the lung either because of acceleration or disacceleration. When you are sitting in a car and if you suddenly deaccelerate, apply a brake, you move forward. So if you are not fasten the seat belt, same way the lung inside, they move forward and backward. That is called as Coop counter Coop injury, acceleration, disacceleration injury. Not seen externally, you cannot see, but these we have to, by clinical examination, has to identify. There is a crush type of injury, bullet injury, Coop counter Coop injury. This leads to definitely the same mechanism: ineffective ventilation, interstitial edema, bronchial obstruction, or atelectasis. The causes, the effect are ineffective ventilation. So when it injury to the heart, it could lead to, when like in a lung, there is a visceral pleura and parietal pleura. In between, there is a small space, have a pleural fluid. Normally 50 to 70 is present. Same way heart has a inner pericardium, visceral pericardium, and outer is the parietal pericardium. So in between also there is some fluid. But when the blood comes from the heart within this fluid, there is no escape. So it compresses the ventricles or a atrium and causes they didn't get a space, heart to expand. And that is called as cardiac tamponade, which is a life-threatening condition. Here definitely myocardial injury is also contusions. So these even 100 to 200 ml blood in pericardial space, this includes the increased intrapericardial pressure, compresses the atrium and ventricle, impairs the diastolic filling and coronary filling, decreases the cardiac output, and leads to myocardial ischemia and a central shock. Same way, myocardial contusion leads to decreased contractibility and impairment of diastolic filling. Vascular injuries, they lead to hemothorax, decreased blood pressure, increase. So we'll have to identify. Depending on the vessel involved, action is taken. In case of diaphragmatic injury, the abdominal viscera or intestinal sounds are heard on the chest. These are the secondary surveys. Again, the tracheobronchial injury, this has cases in our hospital only. You can see when you put the chest tube, endotracheal tube, and when I opened it, the endotracheal tube was just beneath the platysma muscle. It was a complete shattered 360-degree tracheal injury, wherein we put in a first ICD because air was constantly leaking, and then took the patient immediately to the theater. These come in secondary survey. So in secondary survey, simple pneumothorax, hemothorax less than 1500, pulmonary contusion, tracheobronchial injuries, diaphragmatic injury, esophageal injury, and myocardial contusion. And aortic disruption, most of the time this patient die on the spot. But if this subintimal, only the one layer is damaged and it causes dissection, that patient can be saved. Then which patient you require an emergency? Most of the patient, 80 to 85%, 5% patient, you'll have to, they have to be treated immediately. 80 to 85% with your resuscitation, they improve. But 5% you require an emergency room thoracotomy. So these are penetrating trauma associated with pulseless electrical activity like a cardiac tamponade or pericardial tamponade. So this patient has to be taken immediately, like we do external compression, resuscitation. So that is called as internal resuscitation. That allow to relieve the left anterior thoracotomy, allow relief of pericardial tamponade by taking out the blood from the pericardial space, control of hemorrhage, open cardiac massage. So CPR is given, I mean cardiac massage is given, as well as cross clamping of the aorta can be achieved. And so that aggressive resuscitation is so the patient life can be saved by aggressive resuscitation. So these are the those are the conditions for the emergency room thoracotomy. But urgent thoracotomy indicated in cardiac arrest, acute deterioration with hemodynamic instability, more than 500 ml of blood after ICD insertion. It is just very subjective as well as the condition. If the trauma is 2 days prior and you put in a chest tube and 1500 ml blood, so that means there was no active, it was a collected blood. So it was an active hemorrhage has to be there. It's a way, I mean, you have to calculate according to condition and the timing from the trauma. So continue bleeding 200 to 300 ml after initial drainage. That means it indicates active hemorrhage has to be tackled. Penetrating chest injury causing cardiac tamponade, massive air leak, like in that tracheal injury, there was a massive air leak. Major tracheobronchial injury and esophageal puncture require an urgent thoracotomy immediately within 6 hours or 12 hours. So the prerequisite for the emergency room thoracotomy, the nurses should arrange this thoracotomy tray within the near the emergency operation theater. These are the instruments are required. For the ICD insertion, you require a area to clean betadine, clean drape, injection to infiltrate lignocaine, injection lignocaine, blade, straight artery foci. Then to put a tube, you require a tube. After passing a tube, you will need to connect it to underwater. So ICD bag and then 100 ml NS into it and connect it to it. And to fix, you require a thread. With this, I conclude my talk. And I'm very happy to take any questions.
Thank you, sir, for the excellent session on thoracic trauma. Please wait, sir. I request Dr. Padmaja Dawale, Associate Professor, MGM New Bombay College of Nursing, to appreciate him with the certificate. Are there any questions? You are free to ask questions. No questions? Okay, sir. Thank you. So next renowned speaker we have with us to deal with thermal injuries is Dr. Sunil Keshwani, cosmetic surgeon from National Burn Center, Airoli. He is a medical director at National Burn Center, Airoli, Navi Mumbai. His work focuses on 5 verticals, including prevention, treatment, training, rehabilitation, and research. He's very instrumental in setting up the skin bank at National Burn Center, Airoli, and 15 other skin banks across the country. He is a crusader for burns prevention, leading a burns prevention program in the city of Mumbai for the last 35 years. He is also a regional representative for Southeast Asia for the International Society for Burn Injuries for 6 years. His publications include an edited textbook on burns, chapter on burns, and several books and papers in national and international journals. We welcome you, sir. I request our director, Dr. Prabhakar Dasila, to felicitate him.
Forward this one. Doesn't happen. Say नहीं होता. You have to do this. इसका माइक क्या है एंड्रॉइड में कि आई एक माइक है ये चल तो ये ध्यान दो एक का आगे बता A very good morning to you all, friends. It's indeed a pleasure to come to MGM each time and meet Professor Dasila, Prabha Dasila, because somehow we have a very good rapport for the last so many years. I think a good 20 years we've known each other. And she is as passionate about teaching as I am. So as they say, birds of the same feather flock together. So welcome all to this conference on trauma. And I learned a lot of new things that nurse practitioners today are doing all kinds of things, intubations, putting central line, putting intercostal drainage tube. This was news to me, and I'm so happy that you'll be extending a helping hand to the intensivists in the ICU. So welcome to our presentation. Topic given to me was primary management of burns. We've essentially talked about what to do when the patient comes in and why we are doing. So essentially, it's a few do's and don'ts. Very simple lecture, but I think these are basic tenets on which the basic burn management is based. This burn management, what you do primarily will make a lot of difference between life and death of a critically ill burn patient. When you call a patient a major burns, any burns which is more than 20% in an adult and more than 10% in a child is constituted as major. And these patients require hospitalization. So, of course, there are other criteria for hospitalizing of the patient, which we'll talk about shortly. Now, before we get on to the actual management, what are the best first aid for burns? And since you're all senior nurses, you ought to know that what should someone do when you get immediately burned. The tenet is pour water over the burns until the burning sensation subsides. What does the water do? Essentially, water cools down the area, and the affected part has to be kept immersed in the water till the burning sensation is there. So if a hand or a finger gets burnt, keep it in cold water for maybe 2 hours, 3 hours. जब तक burning हो रहा है, तब तक हाथ पानी में ठंडे पानी में होना चाहिए. Should you apply ice? Not here. Ice causes severe vasoconstriction and will make a second degree burn into a third degree burn or a first degree burn into a second degree burn. Because as it is ischemia which happens. Ischemia causes necrosis, necrosis causes death and increase the depth of the burn. So no ice, please. Especially in the very young and the very old, because the very young and the very old can go into hypothermia because the thermostat in the hypothalamus is not that effective. Also, do not apply Colgate, Haldi, ink, cow dung. Because we get a patient that apply all kinds of things. They find Colgate very, very effective because there's got some menthol in it. So there's a little analgesia effect there. So in an emergency, put it, but that has to be wiped out because you put all these inks and all, it's very difficult for the doctor to judge or any clinician to judge the depth of the burn. Judging the depth of the burn is by the appearance. Now, what are the indications for admitting a patient to a burn center? One, as I said, more than 10% burn in children, more than 20 in an adult. Full thickness burn, more than 5% body surface area in adult or child warrants hospitalization. Areas like high-risk areas like face, hands, feet, genitals, which if not treated primarily well, can lead to a lot of morbidity later on. They have to be attended to by a specialist right from day one. Electrical burns and chemical burns. Electrical burns and chemical because invariably they are third degree and they need good care from the first day to minimize long-term morbidity. Inhalation injury. If burns happen in a closed space, the burns may be less than 5%, but if the person has inhaled burns, and these days most of the deaths which happen in high-rise buildings is because of smoke. They don't die of the burn, they die of smoke, they suffocate and die. So that's another thing for admission because patient may be coming to all right, but if he has got burnt in a closed space, admit him for observation 48 hours. Suddenly there will be laryngeal edema and patient may die. Suddenly he may require intubation, suddenly may require a tracheostomy. So don't send such a patient to me. The patient's relatives are not making a zyada nahi hai, khali face jal raha hai. You sign and go. Tomorrow they will hold you responsible if you have discharged. You say, "Aap admit hone ka hai, 48 hours of observation is mandatory if there's an inhalation burns." Burns in combination with other kind of trauma. Many a times you have a car accident, car going very fast and the car catches fire. So that's general trauma of the spine, of the brain, of the other parts along with the burns. So that has to be hospitalized. Burns in a setting unequipped to care for the critically ill. So if they're in a very small nursing, they should be shifted to a bigger center, preferably a burn center. Now, what is the pathophysiology? Essentially, any burn can be divided into three zones. There's a central zone of coagulation, there's a zone of stasis, and there's a zone of hyperemia. Now, the zone of coagulation is the central part. The proteins of the tissues of the skin are coagulated. So that's irreversibly damaged. But the zone of stasis can go either into zone of coagulation or zone of hyperemia. Hyperemia is living tissue, zone of stasis is still living tissue. So if the first primary resuscitation is not adequate, that zone of stasis will go into zone of coagulation and your burn will become from superficial second degree to a deep second degree or from a deep second degree to a third degree. So it's very, very important that your resuscitation has to be adequate and timely. Adequate means enough fluids have to go, timely means it has to be done fast before it can cause ischemic damage. There are various depths of burn. Essentially, you all know the skin has essentially two layers, epidermis and dermis. The epidermis has got layers, stratum corneum, lucidum, granulosum, spinosum, and basal. And the dermis has got two layers, the papillary layer and the reticulum. We're telling you these layers because if the epidermis is burnt, it's a first degree burn. If the papillary layer of the dermis is burnt, it's called a second degree superficial burn. So a first degree and a second degree superficial burn is going to heal with dressings, not requiring any surgery or grafting. Whereas if it involves the reticular layer, that's a deeper layer of the dermis, or the second degree deep burn, or a third degree burn, when it goes to hypodermis or subcutaneous tissue, such burns will always require resurfacing with skin graft. It will require skin grafting. So the depth of the burn decides whether the patient will need surgery or will heal up with conservative management with dressings alone. Now, there's another etiology. One was according to the depth, one is according to the cause of burn. So if it's hot liquids, which normally children undergo, scalds, flame, when the thing catches, body catches fire, or they're concentrated acids or alkalis, which are corrosive acid, chemical burns. Invariably, they are deep if they're concentrated. The dilute acid alkali may not be so deep. Electrical burns, low voltage, high voltage, or lightning, the three classifications, and of course, radiation burns. This is according to depth. I just mentioned to you the first degree, second degree superficial, likely to heal on their own. The second degree, deep, and third degree will require grafting. A pictorial representation. This is a superficial burn involving the epidermis. Just redness is constituted as superficial. Then second degree superficial, there is a blister. If there's a blister, that means it's invariably a superficial burn, not a deep one. So seeing a blister, you must be happy. Itna deep nahi. If you don't see a blister, it's an ominous sign. That means it's second degree deep and third degree over. Second degree deep and third degree deep burn do not have a blister. This is a deep one. This third degree. Now here you see out here, it's absolutely charred. It's become whitish, blackish. It's a thick eschar already formed. The eschar has to be removed as early as possible. Otherwise, the damage, the infection will go deeper and deeper inside. Because eschar separates by sub-eschar collection of pus. So this has to be removed at the earliest. Now, this is another method of assessing the burn by the depth, color, blisters, capillary influence, sensations. Depth I just mentioned to you. The color I said, the superficial burns, when it first degrees are red. As it gets deeper, it becomes pale pink, dark pink, blotchy red, and then it becomes white. Blisters, no blisters in superficial burn. In superficial dermal, blisters present. Mid dermal, they are present. Deep dermal, they are not. So not present is not good. Capillary refill is present in the epidermal burn. Superficial dermal is brisk. Mid dermal becomes sluggish. Now, what is normal capillary return? What's capillary return? Press the lane and look for blanching. And then you look for return of the color when you release the pressure. Normal time for capillary return is 2 to 5 seconds. If it's less than 2 seconds, it's a fast venous congestion. If it's more than 5 seconds, it's arterial obstruction. So there are the various stages we'll be talking about: primary survey, investigations, pain management, secondary survey. Again, we go by the standard thing that you see in trauma, ABCD of burns. That you're talking of airway, breathing, circulation, disability, and exposure. इसमें बात हाँ I can. So this you all know, the ABCD of primary management of any trauma. The same holds true. But in burns, sometimes in pediatrics, you have to be extremely careful if there's a phase burn, because there's a short and narrow airway of the pediatric patient. They can suffocate very easily due to mucosal swelling. We have to look out for signs and symptoms of inhalation injury. What are they? You look for nasal hair. Are they burnt? You have to look for black sputum. Is the patient coughing out sputum, which is black? Is any hoarseness of voice, or is the patient already into stridor using the accessory muscles of respiration? And burns over the trunk, invariably the deep breaths cannot be taken, can compromise breathing. Again, respiratory injury from burns can be of various causes: hot hair, hot steam, smoke, hot particles, aspiration, irritation, gases. According to that, effects are various, which you can see on the slide. Again, in for a burn resuscitation in the upper airway, if the fire is an enclosed space, the person may be confused, altered consciousness, and there may be dysphagia and drooling, in addition to the symptoms I already mentioned. And these are the various airway devices that you see out here, which can be used to intubate such a patient. In the lower airway, the lungs may be damaged due to primary lung damage due to the heat. There may be pulmonary edema due to over-resuscitation, or the person may go into acute respiratory distress syndrome in the later part when sepsis and multiple organ failure come in. Now, these are the bronchoscopic pictures, how edematous the vocal cords are. You can see there. And look at the airway, there's black soot there. So you can see it on a bronchoscopy. So bronchoscopy is diagnostic. I think a bronchoscopy is invasive. There is a little bit of patient discomfort, but it shows you exactly what is there. It shows you exactly, documents the fact that there has been inhalation injury. And when there's inhalation injury, the prognosis becomes worse. So to prognosticate and also to treat, the toileting of the airway can be done. The cleaning of the soot can be done by giving a little bit of bronchoalveolar lavage. How do you diagnose inhalation injury? First of all, you must have a high index of clinical suspicion. There are by bronchoscopy you can diagnose. There are a little more advanced techniques where you use xenon 133 can be used. You can do ventilation quotient lung scanning. There's something called virtual bronchoscopy. I'll show you some pictures later on. And then, of course, arterial blood gases and repeated clinical examination also gives you a clue. Yes, there is inhalation injury. Now, what's your bronchoscopy? This is very useful. You don't have to actually put in the bronchoscopy. This is from outside. It's a non-invasive method. It's fast, simple. No effect on oxygenation because you're not putting anything inside. Patient is not in discomfort, and it is very easy to document and for archiving. So for follow-up and comparison also, it's very easy. And it depicts the relation of the intra and the extraluminal structures very easily. This is how the virtual bronchoscopy. Look at the pictures. They're so good. You don't really have to do a bronchoscopy. So if you have virtual bronchoscopy, you can, there are some limitations of virtual bronchoscopy, but the advantages far outweigh the disadvantages. Look at this virtual bronchoscopy. It's almost as good as looking through a bronchoscope. Today, there have been a lot of advances in the field of medicine, and this is really to the benefit of the patient. Now, what is the initial management of the inhalation injury? Yes, a patient has got inhalation injury. What do? Prop up the patient. 30 to 90 degrees. Why do you prop up? Prop up makes the act of breathing easier because the diaphragm can go up and down very easily. Because when you're lying down, your abdominal contents press on the diaphragm and do not allow downward excursion of the diaphragm. Because if you remember, inspiration is an active process and expiration is a passive process. So when you breathe in, you inspire. If you don't, you expire. You give high flow humidified oxygen, bronchodilators, physiotherapy, nebulization with Duolin, Budecort, heparin, depending upon the condition, different combinations are used. And of course, fiber optic bronchoscopy is a useful tool. Now, when there is laryngeal edema or the patient has been on prolonged ventilatory support with a tube inside or for tracheobronchial toilet, you need to do a tracheostomy. A tracheostomy can be a percutaneous tracheostomy, which is done by an intensivist or anesthesiologist, or it could be a regular tracheostomy, or a disc tracheostomy, or a flap tracheostomy, which is done by an experienced surgeon. These are the kind of patients we get. Now, earlier, 20 years ago, we used to see a lot of women committing suicide or being burned by their mother-in-laws and husbands, known as dowry deaths. Today, I must give you the good news. Last 5 years, the incidence of women getting burned has dropped down drastically. In our burn centers, we are only seeing small children and industrial burns in men happening. Women burns have become rare. So I think that's a good thing, social change that has happened. Now, early intubation, when is it considered? What are the indications? Early intubation, the indications are presence of stridor, the Glasgow Coma Scale less than 8, hypoxia, hypercapnia, full thickness neck burns, deep fascial burns, oropharyngeal edema, burns more than 40% with sometimes where you're likely to have over-resuscitation happening. Prophylactically, you could intubate. And these days, you have laryngeal mask airway also. So it doesn't have to be invasive intubation. You can just put a LMA. And use of direct laryngoscopes, LMA, Bullard laryngoscopes. And the choice of the intubation technique entirely depends on the expertise of the operator. If you're not that great at intubation, the cords are not very well seen, you can blindly put in a LMA. There's no problem. So that's another method. Now, the evaluation for circulation. I think early and appropriate fluid resuscitation and adequate is the other word. The formula used is the Parkland form. 4 ml per percentage per kilo. So minor burns, less than 10% in a child or more than 20% adult, you really don't need to give any IV fluid resuscitation. It can entirely be oral. Patient can be encouraged to take things orally. Now, with this formula, you give the patient fluids and deliver half the volume that you calculate in the first 8 hours, and the remaining half of the volume is given over the next 16 hours. And then after that, you have to go by urine output. It's called titration. If the urine output is on the higher side, reduce the IV fluids. If the urine output is on the lower side, increase the IV. So you have to titrate. So your output has to be monitored hourly. You see the trend for 2 hours, and every 2 hours you make the change. Don't make a change every hour. Every 2 hours, you titrate. What is the solution of choice? IV solution of choice is Ringer Lactates in adults and Isolate P in children. Now, what is the kind of urine output do you want? In an adult, we want 0.5 to 1 cc per kg per hour. In children, we want 1 to 2 cc per kg per hour because the child weight is less. But in electrical burns, the amount of fluid that requires to be infused is very high. You require 2 to 3 cc per hour. Why do you need 2 to 3 cc per hour? You need 2 to 3 cc per hour because you have to flood the body with fluids. Otherwise, in electrical burns, myoglobin urea happens, and the myoglobin molecules can block the renal tubules and cause acute renal damage and kidney shutdown. So you have to wash off the myoglobin molecules before they block. So good hydration, in fact, more hydration than usual is required in electrical burns to prevent kidney damage. There are other parameters of monitoring. You can see the arterial lactates. Today, the ABG comes with a lactate parameter. And of course, there are the advanced hemodynamic monitoring with echo, cardiography, cardiac output monitoring with that, central venous pressure measurements. When do you get altered sensorium in burns? When does the patient become disoriented? Either in the early stage, it happens due to hypoxia or hypervolemia or electrolyte imbalance. So whenever a patient is disoriented, you must suspect hypoxia. Do an ABG, confirm whether it's hypoxia or not. Hypervolemia, check your CVP or do a echo. Or is it electrolyte imbalance? Is it hypernatremia, hyponatremia, hyperchloremia, hypochloremia? So depend on what is what. So you have to suspect all. And a high index of clinical suspicion will help you reach the diagnosis. In late cases, if the patient goes into sepsis, he will again be having altered sensorium, but that's in the late stages, 2 to 3 weeks down the line. These are the various lists of investigations which are done on admission. These are the investigations which we do in the ICU. These are the investigations which we do when the patient is on ventilatory support and the frequency is mentioned. These are the investigations done in the ward on a regular basis. Now, when I'm saying these are investigations, these are all major burns. We are a tertiary care center, the National Burn Center at Airoli, where only burns more than 30 to 40% and above we get. Very rarely we get burns less than these. Again, it's very, very important to know which bacteria is sitting on the body and what antibiotics you're supposed to give. So today is the age of targeted antibiotic therapy, and one must have the right antibiotic for the right bacteria. So normally you take swabs twice a week, and when there's high fever or continuous fever, send blood culture, urine culture, sputum culture. Central venous line, whenever you change, you should send it. Who needs a nasogastric tube? All burn patients, about 20% adult and 10% a child, we put a nasogastric tube, not for aspiration, for feeding. So in addition to oral feeding, we give forced enteral feeding because the caloric requirement is very high. For pain, what do you do for pain? For pain, we have a pain protocol. For adult, we give an infusion of 50 ml normal saline with 100 milligram ketamine, 100 milligram tramadol, and 10 milligram of midas. For children, the ratio becomes little less. And this is given differently for background pain, that's resting pain, for procedural pain, and breakthrough pain. For background pain is 0.5 cc per hour, can go up to 4 cc per hour. For procedural pain, we give as much as 10-15 cc per hour or even 20 to 30 cc per hour. It has to be titrated. Monitor only the saturation, SpO2, and the patient is on nasal prongs. And patient should be talking, yet pain-free. So this is an analgesia protocol, not an anesthesia protocol. Again, this does not require any starvation. So dressings can be done with an analgesia protocol without any starvation. This is the patient in the IBCU, OT dressing going on. Tetanus prophylaxis is a must. For primary management assessment, it's very important that these patients are susceptible to hypothermia. You have to keep them warm. They're susceptible to infection. You have to keep them clean. And they're susceptible to hypovolemic shock. You have to prevent fluid loss and replace the fluids. Prophylactic role of antibiotics is not there. Give antibiotics only on the 3rd, 4th, or 5th day once you see some bacteria growing and the wound swabs are positive or the patient is clinically running temperature. DVT prophylaxis is given to all patients. We normally give Clexane. And patient not so affording, we give the non-fractionated heparin, crystalline heparin. Trigger for blood transfusion, we give blood only if the hemoglobin drops below 7. Above 7, we don't give. Lesser the viscosity of blood, better the perfusion. Propranolol is another drug which is given to reduce the hypermetabolic response. We'll not talk about. Oxandrolol is another drug which is a synthetic anabolic steroid hormone. It decreases the length of stay for adults and may enhance erythropoiesis in children. These are experimental. We don't use it much in India. It's used in the West, again, very experimentally. High-dose vitamin C is something which we have been using in the early resuscitation phase. And if you give this high-dose vitamin C in the first 48 hours, it reduces the amount of IV fluids that the patient is requiring, and the chance of going into hypervolemia and pulmonary edema gets reduced. Nutrition, very, very important. Because giving antibiotics alone will not be enough. You have to see that the nutrition is good. If the nutrition is good, the body can fight back the infections and the patient will survive the burn. So I think the standard Curie's formula is to be followed. We have our own enteral feed. We give the buttermilk diet, which is 1 liter of curd, 4 eggs, 4 bananas, and 40 tablespoons of the sugar. This is given through the Riles tube. Our nurses prepare them, our nutritionist prepares them in the ward, made fresh every 4 hours and given to the patient through the tube. So 2 hourly feeding, aspiration before next feed. If the aspirate is high, next feed is omitted. Chest physiotherapy is extremely important because the commonest cause of death in burns is not burn wound sepsis, it is hypostatic pneumonia and lung problems. So a very 24-hour physiotherapy is given in our hospital and should be given in every place treating burns because every 2 to 4 hours, chest PT has to be done, nebulization has to be done, vibration, percussion has to be done to see that all the alveoli open up and they don't go into atelectasis and pneumonia. Active and assisted range of motion to prevent deformities and splintage. Tracheotomy in the early stage if there is compartment syndrome, pain, pallor, pulses, paresthesia, and paralysis. When that happens, before that happens, you must envisage circumferential burns need a fasciotomy. Sometimes you need just an escharotomy when there's a thick scar. Fasciotomy means you go through the fascia. Escharotomy, you go only through the skin. A lot of superficial burns, we just put there's something called collagen dressing. Most of the burns in children are superficial by and large. The healing is very good. Apply collagen the day they come and scrub it nicely with Vita scrub and saline. Put collagen on day one with a little bit of KTM protocol, pain management protocol, and the wound heals beautifully, very fast in about 2 weeks' time. This is how collagen is applied. This is how it looks. This is the patient healed. How well he heals only with collagen, no surgical management. OPD basis. Again, today we are on the last few slides. I need another 5 minutes. Today the dictum is what causes infection in burns is the dead skin. We must remove the dead skin from the body as early as possible. So within 48 hours, dead skin has to be removed because dead skin causes colonization by bacteria. The bacteria multiply, cause bacteremia. Bacteremia, you develop clinical signs of sepsis, becomes septicemia, and you will end up with multiple organ failure. From multiple organ failure, it becomes very difficult to reverse the whole process. So you kind of preempt it and prophylactically remove the dead tissue within 48 hours. So all in all, friends, today you have to be very, very aggressive. And today with the advent of better critical care management with critical care nurses, with intensivists, with microbiologists sitting there, a psychologist, a psychiatrist, good nurses who form the base of the pyramid of burn nursing, good doctors, aggressive management of burns, and availability of allografts in skin banks, we are able to save major burns. What are skin banks? Skin bank is a place where skin is removed from deceased donors or dead people within 6 hours after death. This skin is preserved in a skin bank. It can be preserved in a skin bank for as long as 5 years. This skin helps prevent death in the patient. Moment your patient gets burnt, remove the dead tissue and apply these allograft to skin from the bank. Pain goes away, nerve endings are covered. It prevents entry of bacteria. It prevents loss of plasma or exudates, and ultimately it helps in faster healing. So antibiotics are less are required. Infection does not happen if you put allograft soon. And allografts and skin banks have made a big improvement in the outcome in terms of morbidity and mortality in burn patients. Thank you, ladies and gentlemen.
Thank you, sir, for the excellent execution of the lecture. Sir is well identified for the excellent burns care at his center. And when it comes to burns, nobody else could be the right person to speak on burns. So we are happy and we are grateful that you have accepted our invitation and joined us today. So I request our director, Dr. Prabhakar Dasila, to appreciate him with the certificate. Thank you. So now we'll be dispersing for a 10 minutes tea break. Please ensure to come back on time. Moving ahead with the next session of the day, we have the next speaker, Dr. Dikpal Singh Jadhav, Associate Professor, Department of Neurosurgery, NJ Medical College Hospital, Navi Mumbai. He has completed his MBBS from SAIT GS Medical College and KEM Hospital, Mumbai. His MS General Surgery from GMC Nagpur, MCH Neurosurgery from SAIT GS Medical College and KEM Hospital, Mumbai. He has rich clinical experience. He has participated in multiple workshops and camps and also plenty of publications to his credit and multiple participations in various national and international forums. We welcome you, sir. I request Manisha, Tutor, Indian College of Nursing, to felicitate him.
Good morning, everyone. Good morning. Thank you. So I'm not used to stand and deliver my speeches as such. I'm supposed to move, but now that's going online, so I will have to stand. And I believe that always better to have an interactive discussion. First question, how many are from NGM? Most of it, yeah. So myself, Dr. Dikpal Singh Jadhav, I am a neurosurgeon by practitioner. She has introduced me. Let's start with how many of you seen head injury patient as such? I have first encounter. Quite a lot of them. So that will make my job easier. You know, we have in India the highest population of head injury patients in the world. And while I'm speaking, there are 13 patients already of head injury being admitted somewhere in India. So till I finish, there are around 400 patients already being treated or being admitted. Most common cause of head injury is road traffic accident, goes by the saying. And after that comes fall and assault. Assault is more in foreign countries. In India, we have road traffic accident because most of our road comprises of two-wheeler and moped still now. 70% of our vehicular transport is two-wheelers. So motorcyclists and pedestrians are most commonly are involved in RTs. With time constraint, I will stick to only 3 objectives for this session. That is basic classification of head injury, initial clinical assessment, and initial management of head injury patients. So how do you classify head injury? I would say we can classify it as focal and diffuse injuries. In focal injuries, we have injuries to scalp, injury to bone, and intracranial bleeds. What do you think, is injury to scalp significant or not significant? Yes, no. Good morning. Yes, good. So was very low, yes, but still I'll take it as yes, because I have seen a patient with scalp injury going into shock and she has to be dissociated. She was a South Indian girl with long hairs. Her hairs were trapped in the rear wheel of a bicycle. Her scalp was avulsed and she bleeded like anything. This she was louder than yes. So now maybe next time I'll have larger yes. So scalp injuries are not to be taken lightly. They can bleed like hell. They can make patient bleed to an extent that she can go in shock. She or he can go in shock. So simplest method to apply pressure dressing can save a person's life. Coming on to fractures, fractures can be simple fracture, compound fracture. Simple is when skin cover is there. Compound is when skin cover is not there and it's open air fracture. It can be undisplaced fracture or a depressed fracture. Undisplaced goes by the words meaning it's simple linear fracture, and depressed is when it's going in the parenchyma. Or we can have vault fracture, upper cranial fractures, or skull base fractures. In this, skull base fractures are probably the most dangerous ones. A little bit about frontal versus occipital fracture. Frontal bone is weaker compared to the occipital bone. So frontal bone fracture usually produces depressed fracture, and it can produce what we call as CSF rhinorrhea, which is to be watched up in ward also. Occipital bone that way is thicker and it usually causes countercoup injuries. Countercoup is opposite side. So blow is on the back, but injury is on the front. As you can see in this CT scan. Blow is on the back, but patient has developed contusions on the front aspect, or the frontal aspect. And frontal injuries, as I told you, bones are weaker. So they fracture and through nose, they can develop pneumocephalus. So air in the word says pneumo means air, cephalus is air in the brain, in the cranial cavity. Now coming on to intracranial hemorrhages, there are different types of intracranial hemorrhages. You must have seen, those who have lifted their hand, they must have seen these patients, extradural, subdural, subarachnoid, intracranial bleeds, then contusions. So to understand this jargon, you have to just remember this simple diagram. So these are the brain coverings. Upper was up, the outermost is the scalp, then comes the skull, then the dura, blue is the dura, forget about these two layers. And then comes the arachnoid, and then comes pia. Pia is very adherent to the bone, brain, so we don't have to worry about it. So any bleeding between these two layers is extradural, outside dura, or epidural, outside dura. Anything below this, below means sub. So this is below dura, subdural. Anything below subarachnoid space is subarachnoid hemorrhage. Beauty of this space is all the blood vessels that goes to brain are in this space. So just to remember, I'll just show you a few pictures so that whenever a CT scan or something is thrown at you, you should be able to identify what it is actually. So a EDH, the extradural hemorrhage looks like this. EDH, E for idli, E for idli shape. Simple to remember. Okay. Now subdural, below the dura, you can see a crescent moon-like bleeding. In acute situation, it looks like this. Whatever is acute blood which has recently bled will look white, as you can see in this also. Thing which has bled just now will look white. But if we don't treat this, patient is fortunate enough to live, he can develop bleed like this, which is a chronic bleed, which looks less hyperintense. Okay, so this is not a normal CT. I don't know how quality of picture you're seeing, but there is a bleed here, a liquefied subdural hemorrhage. Now coming on to contusions and SH, these are probably most common thing that you must have been seeing, because other two will get operated by us and then we will get them in post-op. So these are the contusions. There are small hemorrhages in the brain parenchyma because of the impact. And subarachnoid hemorrhages, as I told you, they are in subarachnoid space because of the rupture of small vessels. They can form like this. What is concussion? Concussion is something that you will encounter more in your family. So they will call you and tell, अरे बच्चा गिर गया, थोड़ी देर रो रहा था, फिर थोड़ी देर बेहोश था, 2 बार उल्टी हुआ, लेकिन अभी ठीक है, CT scan करा लो क्या? So these are all concussion patients. So they have some brief history of altered sensorium or episode of vomiting, but then they recover after maybe 6 hours. So 6 hours is the cutoff, what we usually give for concussions. And concussion is, by the way, diffuse injury. Now I'm moving on to diffuse injuries. The more grave diffuse injury is diffuse axonal injury. Diffuse axonal injury means if you recall your anatomy, gray cells or the brain cells start from the cortex, they go to right to your gray tube. Okay, so there is a long cell. Whenever there is sudden acceleration, deceleration injury, yeah, boom ke laga, so that causes shear pressure on the axon. So that causes diffuse axonal, the simple way of putting it. So the axon, sorry. So there is axonal injury, and this can be seen as small contusions on the CT scan. Usually the CT is normal in concussion. Initial phases, CT is normal in diffuse axonal injury also, or most of the time it is normal. For diffuse axonal injury, ideally we need MRI. We'll come to that later. But this is what diffuse axonal injury actually means. As I told you, CT is usually normal, but the patient is not. He has, as you realize, patient has moved a lot. Patient with diffuse axonal injury are not that stable. They move a lot. CT does not showing anything. If you could appreciate, there are small hemorrhages that can be seen there. Now moving on to examination. So if a head injury, or for that matter, any trauma patient is wheeled into your casualty, you are the nurse practitioner on call. What is your first thing that will do? Good morning. Good morning. If you don't answer, then I will have to point somebody and ask. Please, whatever. We have limited time. First thing, sorry, vitals, fine. Next, there are lectures going on since 2 days, I think. A, B, C, D, E. So first thing is airway, breathing, then circulation, then we will come to disability. So I'll concentrate more on neurological examination. So general physical examination, as rightly pointed out by somebody. Then we do neurological examination. First thing that we see is GCS, okay, Glasgow Coma Scale. So that is an objective, what we can say, objective evaluation of a patient as per neurological. Okay, so there is a definite scoring system that will come to that. And we see general physical signs, like first thing is pupils, then is there any evidence of skull fracture on palpation? Is there any evidence of now vault fracture? I told you 2 types of fracture, vault fracture, skull base fracture. For skull base fracture, what we can do? We have some indirect signs like the Rapuna sign, battle sign. So we have to look for that. We have to check for facial bone fractures. Why? A. Why? To see for A. A was airway, exactly. So we have to check for facial fractures also. So what can happen is there's nothing there, airway, you can see nothing but a mandible is fractured and patient can go into apnea because of tongue cord. So we have to check for facial fractures also, and rest all spine examination. Spine is the next lecture, so you can catch up with. So as well as I was telling you, Glasgow Coma Scale. So that is an objective scale, entirely theoretical. I just want to point it out. There is no Glasgow scale score of 0 in GCS. Okay, it can be minimum 2T. Minimum score can be 2T. T is when patient is intubated, or new advances in this is NT has come. When you cannot assess something, both eyes are swollen, then you can write NT for that, not tested. Okay, and one more advanced, more refined score that has come after GCS is GCS P score. In that, P is for pupils, and you calculate GCS score and you subtract the number of dilated pupils from that. That will give you GCS P score. So this is, you must be aware of GCS scoring. One thing that you should understand in GCS, motor is the most important parameter that we look for. And 2 most important things that you have to say is decorticate and decerebrate rigidities. There are few mnemonics for somebody if they want. I'm not that into mnemonics that way. So decerebrate. So cerebrum is gone. Decorticate is only cortex is gone. So what do you think is the worst one? Good morning. Decerebrate is the worst one because entire cerebellum is gone. Okay. So which posture is bad if you see this fellow or this fellow? First, second. So you'll call me when you see this or you see this? Second. No, you'll call me for both the postures. Thank you. Pupils, focal signs, as I told you. I don't know if you could appreciate, but this, both eyes are beautiful, but this beautiful eye is dilated compared to this. So these are localizing signs. So eye which dilate first, usually pathology is on that side. And the skull base fracture signs we were talking about. So hemotympanum is one, battle sign is bruising behind the ear, and these are Rapuna eyes. So examination summary. Vitals are important as rightly pointed out. But the first thing that you should look after is don't discount anybody as concussion. First alarm should raise whenever the person is saying abhi ye zyada so raha hai compared to us. That should raise your alarms. So somnolence is probably the first sign that the patient is returning or started returning. Pupillary changes are late per se, but still I can say till that time patient can be salvaged. When the patient becomes comatose, both pupils are dilated and starts posturing this or this, then probably patient outcome would not be that great. So even after intervention, probably we'll have some dysfunctional patients. Regarding radiography, I told you first investigation that we do for neurological assessment is good morning. CT scan, yes. So first we do CT scan. There are certain criteria for which patient CT is to be done. which patient it's not to be done, entirely theoretical. Usually patient with low GCS, mild to moderate, or we can say moderate to high risk, high head injury. Then if history is not known, extremes of ages, there is history of some anticoagulation, then usually we do CT. Important point I will like to raise is when do we do follow-up CT? MGM guys know whenever we are around, we ask repeat CT hua kya? Usually after 12 to 24 hours. It also depends when was the first scan done. If first scan was done immediately after trauma, then we like to repeat it earlier. Because usually first 3 to 4 hours, we don't get much in the scan. And if the patient, and so it could be a routine follow-up CT or an urgent follow-up CT. So if patient in first CT, there was not much of a finding, it was in gray zone, conservative operative kind of. And if the patient is now deteriorated, so usually we then ask for urgent CT. Spine will be covered. MRI, what is your take on MRI? Is it required, not required? Yes, no, Patak. Yes, no. MRI is usually not required in acute trauma settings. Okay, for diagnosing diffuse axonal injury, yes, it can be done, it is required, but usually not required. If you could read your CT scan better, usually not required. Book says yes, you write in your books that for diffuse axonal injury, I will do MRI in later stages, but practically not required. I don't want to send my unstable patient in MRI for half an hour. For spine, yes, required, but that too on a later date when the patient is stable and when we want to intervene. But again, spine patient who is neurologically stable, but with fractures on CT scan, again, I will be like, whether should I do MRI? Because while transporting, he might develop deficits. Pathophysiology in just a slide. So there is a primary injury, there is secondary injury. Primary is that occurs at the time of trauma. Secondary is something that we are here for. We are here to prevent that secondary injury. So hypoxia, brain edema, hypoglycemia, hyperglycemia, electrolyte imbalance, that is something that we can change. Or whenever there is raised ICP, that we can alter. But primary usually is not in our hands. So you have seen the patient, you have sent all the investigation. What is the first thing that you'll do? Patient is there, you have the investigation. He is not speaking. Patak, good morning. Airway, excellent. So that doesn't change. A, B, C, D, E, that doesn't change. So patient is not speaking, airway is endangered, you have to establish a definitive airway. So in ER, you have to monitor vitals, avoid hypotension because that can decrease cerebral perfusion further, cause ischemia, infarction, and then cerebral edema. Again, so you have to avoid hypotension. That doesn't mean we have to have hypertension. Usually we keep MAP of around 100, 105. So that is our usual target. Oxygenation is important. So head trauma patient wheeled in till anything has been arranged, at least you can take IV line, put in, run some fluids and oxygenate the patient with O2. Intubation, obviously, whenever there is a threatened airway, as we have discussed, where that patients need definitive airway. Now, ICP is something that is talked about a lot in ICUs, wards, everything. ICP is intracranial pressure. So what are the measures to decrease intracranial pressure? Why intracranial pressure is given that importance? Because cranium is a closed cavity. There are 3 things in it: brain, CSF, and blood. Whenever one thing increases, something of the other 2 has to decrease. And it's made like that. If something decreases, if CSF decreases slightly, we can manage. ठीक है, थोड़ा चल जाएगा. But whenever pressure increases further, ICP increases, that intracranial pressure increases, that can cause devastating effects. So that's why ICP is given that importance. So what are the measures to decrease ICP? Bedside. It's already been displayed. So if you have seen, we usually ask you to keep the patient propped up. I personally ask that the neck should be straight. Many of you get irritated by that, but the reason is if the head is not in midline, it can compress jugular vein, which drains the brain. So if it gets compressed, outflow is blocked. When the outflow is blocked, if it is blocked in our toilet, what happens? Unwanted things come up. So if it is blocked here, venous blood does not come down, increases further ICP. That's why neck should be in center. Obviously, we need to look after cervical spine so that nothing more damage is to be done. Next is, so these are the basic things: elevate, propped up, and keep the head in midline. Osmotic therapy is the next thing that we usually start, is mannitol and 3% NaCl. How is mannitol preferred? Why? Which one is preferred over which one? Mannitol or hypertensive? Which thing you have seen to be used more in your ICUs? And 3% NaCl, some say mannitol. So my take is, when you need to have acute control, you can give mannitol. Mannitol is rapidly acting. 3% you cannot give that rapid. Okay. So mannitol, and usually mannitol acts for 3 to 4 days. After that, it has not much of a role, ideally. So that is the time when we can pull in a hypertonic saline. So both are osmotic therapies for raise ICP. After that comes sedate and paralyze the patient. That is also, you must have seen. Hypothermia and hyperventilation are not that recommended, and if at all they are done, they are for shorter duration. Maybe patient is to be taken in OT in next 1 hour, 2 hours. Then that is the time when we usually take apply these manuals, or we are operating, brain has become very tense. That is the time when we tell our anesthetist to increase the respiratory. So they are just time buying procedures. They are not for treatment as such. And if nothing is working, then surgery. This is something that you have to look after in ICU. What is delayed deterioration? Have you seen head injury patient getting deteriorated after 2 to 3 days? Yes. So what are the usual causes? What do you tell, and what the clinician or the in charge tells you the next? So these are the usual causes. So most of the time, as I told you, we require follow-up CT to look for whether there is increase in the intracranial bleed or something like that. Sometimes edema increases. So these contusions are very notorious. They can produce more edema. After maybe 24, 48 hours, there is increase in cerebral edema, and that can cause deterioration of it. Next thing is hydrocephalus. Hydrocephalus, normally we have CSF in the brain, in ventricles. Whenever the CSF increases, causing pressure on the brain, that is called as hydrocephalus. So patients can develop hydrocephalus. Common reason is if patients have intraventricular bleed, that can obstruct the outflow of CSF and cause hydrocephalus. So that requires urgent attention. Tension pneumocephalus. Do you remember one slide I show you pneumocephalus with twin peak sign? So sometimes that air itself causes pressure on the brain. Simple maneuver like tapping the air can save person's life. Seizures. Patient with contusions and all, if sometimes what's happened is IV line is out. Maybe that time anticonvulsant has not been administered. So this patient can develop seizure, and seizure is not always tonic-clonic. Person will not always move his limb in tonic and clonic posture. There can be absent seizure, subtle seizures can happen. That can also cause deterioration. And in post-ictal phase, you can find patient as unconscious. Then you will not realize what has happened exactly. So seizures are one of the causes. And metabolic abnormality. This, our MGM guys will know, we always ask for what is the sodium of the patient. So usually in brain injuries, sodium goes up and down. So that is why we ask for sodium. So metabolic abnormalities, second, is also one of the important causes of deterioration. And that can be easily addressed and treated. That's why metabolic abnormalities are important. What are the nursing goals here? So as in the first contact with patient, you have to do early detection of deterioration. How to detect, what to suspect, you know it now. Infection prevention. There are usually these patients have multiple lines, multiple tubes, CVP line, arterial line, Foley's catheter, RT tube, RT. You have to keep those as much as possible sterile. Bed sores, exactly. You have to monitor the class 4 workers or physiotherapists and ask them to take steps to avoid getting bed sores. And chest in the same fashion. Chest infection is probably the major killer after 14 days. DVT prophylaxis, yes, we can have mechanical prevention or pharmacological prevention for DVT. Nutrition is something that is probably the most important role. Patient is in catabolic state. Catabolic is when requirement is more, but intake is less. So there is no upload, but there is a lot of download. So that way you have to understand nutrition is very important. What are the discharge instruction you give? So this is just a sample that ideally you should tell your patients on discharge when he has to visit hospital and on urgent basis. So change in level of consciousness, as if you remember, I told you somnolence is usually the first sign. So you have to make that point clear. Abnormal behavior, excessive irritability, or is not moving at all. Increase in headache or vomiting. So this is what usually patient will come back to you, but increase in headache that was not previously there, and vomiting which is persistent. So you have to make that clear. Weakness or loss of feeling in any of the limbs, that is paresis or plegia, then he has to come back as early as possible. And fits, seizures, that is to be conveyed. Any questions? I asked you so many, you deserve one. I'll wait for 10 seconds more. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Your time is up. Thank you. Happy Holi in advance.
Thank you so much, sir. I request Manisha, tutor NGM Bombay College of Nursing, to appreciate him with the certificate. Moving ahead, I'm introducing the next speaker of the day, Dr. Akash Sarogi. He's a joint replacement surgeon, HN Reliance Hospital, Sarogi Healthcare, Malad, Mumbai. So, sir is a gold medalist wherever he was, and he has multiple fellowships to his credit. He's a recipient of many national and international awards. He has rich publications to his credit. He has done various podium presentations and poster presentation, and also has won prizes in same. He's the most invited guest lecturer and also a lifetime member of various professional organizations. He has participated in various medical camps and also disaster management services. And also he has attended various workshops and conferences in national and international forums. We welcome you, sir. I request Snehal, tutor, NGM New Bombay College of Nursing, to felicitate him.
Thank you. Well, thank you so much for that kind introduction. So, what is a joint replacement surgeon doing over here? Talking about spine and spinal trauma. Shouldn't it be a spine surgeon who should be coming in and talking about this? Are we mistaken? No. Why? Because spinal trauma is everyone's responsibility. Whether it is a doctor, it's a nurse, it's a ward boy, sometimes even a common man. So we need to be aware of this spine trauma. So I got very excited when I got invited for this talk that yes, they have chosen the right person to talk about this. right? So let's get into this. So spine and spinal cord trauma. Why is it important? Many injuries can be very dramatic. You may have a lot of blood on the floor and you will see that, oh, ye cut gaya, wo cut gaya. But spine trauma can be blunt or it can be penetrating. And both of them can be equally serious. Patient may present with the neurodeficit or may not present with the neurodeficit. So any injury case that we are dealing with, assume that there is a spinal trauma. And unless you have ruled it out, that okay, I have ruled it out, there is no spinal trauma, all the precautions of spinal trauma should be undertaken. So this is what we want to learn, where we are going to use a little bit of our ATLS guides as well, where we learned ABC from them, and now we have adopted it to the Indian scenario. How do we manage this patient? How do we document? How do we communicate with our colleagues? So typical case scenario, what we usually say, it's a 28-year-old male who has fallen from 5 meters height, and he was wearing a hat. The bystander reports that the patient landed on the head first, and the neck got hyperextended, right? No injuries were reported. The skin was warm, the breathing was shallow, and not moving arms. The blood pressure was 80/62, heart rate was 58, respiratory rate was tachypneic, and GCS was 15. So, what injury do you think the patient may have sustained? Can we ask you? Yes, ma'am. So, ma'am says spine injury. Why? Because the spine lecture. Any other injury is possible? Cervical spine. Anything else? Anybody falling from height, significant height, landing on the floor? Head injury, okay. Spine injury. Any injury. The answer is any injury is possible. So which are the most two common mechanisms by which a person may sustain a spine injury? One we talked about, which is fall from height, which is the second most thing. You see a lot in MGM, I know that. RTA, right? So any patient who comes to you who has fallen from the height or has sustained an RTA, you are going to think about the spinal injury, right? So what other mechanisms of injury other than fall from height or other than RTA? What other mechanism? Any other mechanism of injury? How a spine could be injured? Anybody? Be louder than that. Come on, yes. What about something falling on the head? Right? A big weight falling on the head. Can that cause spine injury? Yes, right? And sometimes even deep sea divers, they get a lot of spinal injury, right? So these are rare mechanisms. The most common ones that we see are road traffic accidents and fall from height. So what types of shock? We all know what is shock. What is shock? Yes, sir. Inadequate tissue perfusion, correct. So that is shock. And what are the various types of shock we know of? Okay, that's a lot for me. Can we ask one person? Yes, ma'am. What types of shock do you know of? Yes. Most common? Hemorrhagic shock. So can a spine injury patient suffer from hemorrhagic shock? Yes. Why? Yeah, any other organ injury is possible along with it. So spine injury patient may very well be suffering from hemorrhagic shock. And what particular shock are we interested in this patient? Neurogenic shock. Why? Let's go back and see. Could you see what was over here? Skin was warm. What do you expect in hemorrhagic shock? Cold skin. Why will a neurogenic shock patient have warm skin? Why? What happens in the periphery? The sympathetic tone of the vessels is lost and you will have vasodilatation. And despite the patient being in shock, you may have warm extremities in a case of neurogenic shock. Everybody's clear with that? Okay. So these are the types of shock. Every possible type of shock is possible in a fall from height patient. So it's not necessary that it's a spine injury, we are dealing with only neurogenic shock. Right? So what signs and symptoms? We'll talk about this. So how will the patient present to you? Sorry? I have got a spinal cord injury. How am I going to present to you? Let's ask at the back. Yes, ma'am. Yes, yourself. How do you think I'll present to you? Don't worry, it's okay if it's wrong. Tell me. Ask your partner to help you. Sorry? They may not have seen the patient. Okay, I'll pardon you for this. Who has seen the patient? Spinal cord injury. Nobody has seen a spinal cord injury? Yes, you have, but you may have not recognized it. And this is what I expect when I ask most of the audience that, what do you see? What do you see? Everybody's silent. Why? Because the patient mostly does not complain. There is no pain associated in most scenarios, especially if you have a neurodeficit. All that you will see is that a patient is not able to move his hands or not able to move his legs. Now, what is the problem with this? Suppose I have some femur fracture, but along with that, I also have a spinal cord injury and I have lost all the sensations over here. So what will happen? A normal femur fracture. Everybody has seen a femur fracture, right? Yes. And how do those patients come to us? Pain, shouting, right? But a patient with a spinal cord injury with a femur fracture, will he come with that? Probably no, because he cannot feel it. So pain is a very, very important mechanism of the body because it takes the doctor to that particular site. But this is the problem with the neurological injury, with the spinal cord injury, that there may be other injuries associated which may go unnoticed because the patient is not complaining of pain. Everybody clear on that? Right. So how should you manage the patient? This is the most interesting part. So yes, how would you manage this patient, ma'am? Any patient, trauma, how do you manage? Yes, can one person answer? Who wants to be? Yes, do you want to answer? Okay, so what principles are you using? A, B, C, D. Okay. Can someone tell me what is A? Wrong answer. Can someone tell me what is A? Absolutely. What does A stand for? Airway and cervical spine immobilization. Why? Why cervical spine immobilization is so much important that it has been clubbed with A? Why not with B? Why not with C? Anybody? Yeah? Come on, louder. You guys know it all. Yes, tell me. Why is it important? Why cervical spine immobilization is important? Correct? It can cause instant mortality in some cases, but instant morbidity. Cervical spine is injured, you don't stabilize it, patient is quadriplegic. क्या फायदा है वो लाइफ का? Even if you save the life of the patient, if all the four limbs are not working, what's the point? Right? So A is airway and inline stabilization of the spine. Right? I need a volunteer. So can you come here? So when each of you are dealing with a trauma patient, you might be going to your village. There is no doctor available while you're on the way, and you may be the most learned person, and there is an accident you may witness on the road. You are the only helper. So you have to deal with the trauma by yourself. Each one of you should be well equipped with trauma management, right? So when you deal with A, I want you to hold your hands like that, do that, do that. And whenever you go to the patient, open your hands and you're going to stand like this. Both these hands will go on the shoulder of the patient like this. both the forearm is going to hold the head of the patient and you're going to talk to the patient, right? Ganesh, ऐकायला येतं का? नाक सांग जरा. Right? This is the game that each of you is expected to have when you're dealing with a trauma patient. Trauma patient diet don't work like this. Ah, kasa hai Ganesh? No, wrong. What are you going to do? The first thing you're going to do is go like this, hold on the shoulder of the patient, hold between the forearms. Ganesh, kasa hai? Naak sang, hold naak sang zara. This is what you do. And this is what is A. Everyone clear with that? Great. Thank you, sir. Now, what does B mean? What is B? Breathing and ventilation. Okay, you become smart now. What is C? Okay. So, what if the patient is not breathing? What are you suspecting? Patient is dead? No. Then what is it? So B may be affected. You might have to consider doing what to this patient? You try to respond to the patient is not responding. What do you do? Assuming that the patient is not dead. You might have to secure a definitive airway, right? And probably ventilator and involving your anesthesia colleagues and ER colleagues. Okay, fair. So high cervical spine injuries, you may have complete paralysis of the diaphragm, right? Diaphragm is supplied by what nerves? And that's when cervical spine injury can cause respiratory problem. So for this patient was unable to move or feel legs. Patient can move fingers and wrist bilaterally, beat triceps, and all those things, right? So some form of neurological involvement is there, where some muscles are not working, some sensations are not working. You are not sure whether it is C1 or C7 or C5. So the question comes that at what level is the suspected spinal lesion? What will be your answer? Sir, not my problem. The neurosur will come, neurosurgeon sir will come and he will sort it out for me. Wrong answer. Each one of you should know what is the approximate level that we are dealing with. If it is too high a level, the patient may go into respiratory paralysis. Right? You should at least know whether it is cervical spine injury or lumbar spine injury. Right? So we all are going to do one very simple exercise on how to know the level of injury. Right? I want all of you to stand up, please. Okay? Now you can do both sides also. We are going to talk about C5, C6, C7, C8, and T1. The levels, right? So everybody bend your elbows. This is C5. C5 is elbow flexion. C6, wrist extension. Wrist extension. C7, elbow extension. C8, finger flexion. T1, finger extension. Simple, very simple. Should we repeat it once more? So C5, C6, C7, C8, and T1. We talked about 5 main myotomes, and these are the 5 main myotomes which get affected in a cervical spine injury. If your patient can do all of them, then probably you can rule out those. Whatever patient is not able to do, probably that is the level that you're looking at. Very simple. Don't be seated. Let's do the lower level. So L2, L3, L4, L5, S1. Right? L2 is hip flexion. Come on, do it. Find space. Right? L3 is knee extension. L4 is ankle dorsiflexion. L5 is EHL dorsiflexion, great toe dorsiflexion. And S1 is plantar flexion. Repeat once more. So L2 is hip flexion. L3 knee extension. L4, foot dorsiflexion. L5, toe dorsiflexion, great toe. And S1 is plantar flexion. Simple, not difficult anymore. So these are the myotomes that we know, and we know that if they are involved, that is the level of injury. Sometimes you may have unequal levels on both sides, because the inflammatory response of the body may be different on different sides. Right. Now, what resources are available? Today you remember, tonight you say, oh wow, what lecture, I learned everything. Tomorrow I'm going to document it like that. 1 week later, अरे वो L4 क्या बता रहा है सर ने, मैंने record नहीं किया. Right? So what do you refer to? You refer to the ASIA chart. ASIA. Please note down. Google it. The ASIA chart. It's just one chart. And this is a uniform mode of communication. Duty paper handover देते, ASIA chart का handover मिलेगा. That my ASIA chart finding is this. This is what I'm handing over to you. So it creates a uniform channel of communication. Fair enough? So that is the resource that is available for you. Now, why is it important? Why is it important to document it, have uniformity? क्यों जरूरी है? एक बार न्यूरोसर्जन सर ने आके देख लिया, डॉक्यूमेंट कर दिया, हो गया ना फिर. Sir is not going to be there in the ward all the time. The patient may have a changing neurological scenario. How will you know whether the patient is improving, worsening, or staying the same? So, a uniformity in examination and documentation will help us whether our treatment is working or not working. Everybody clear on that? So, yeah. So, patient is restricted on the, how do you restrict the patient and when do you restrict the patient? Anybody, come on. Yes, that side. Does anybody want to answer? That how do you restrict the patient? Let's talk about cervical spine first. How do you restrict the cervical spine? You keep on holding it all the time. Collar. Have you noticed कि collar पहनाने के बाद में patient ऐसे can they or can they not? So मैंने तो collar लगा दिया, my work is done. Anybody, come on. Have you seen something on the sides? So a cervical spine collar application will not restrict the rotation of the spine. The rotation will only be restricted if you have one block over here, tape and tape on the chin and the forehead. Right? That is how you immobilize the cervical spine. What about the lumbar spine? Lumbar spine immobilization also should ideally be done by the ambulance guys. They should bring the patient on the long spinal board. How long will you keep the board? Sir, forever. Our neurosurgeon is going to come tomorrow. He's busy today, so he doesn't work like that. Why? Why can't you keep the spine board until tomorrow? Come on, your work will increase. What will happen to the patient if you keep a hard board on the back for a very long time? Pressure. So that's why you want to remove that board as early as possible. Once your neurological examination is done and the neurosurgeon or the spine surgeon has recommended what should be done, then you can probably take up the board and do the needful. Right. So for this patient, crystalloid was given, the blood pressure slightly improved. Imaging. Which patient requires an X-ray, a CT scan, or MRI? It's a very important question. Any thoughts on that? Anybody? Anybody? Why is that? Sir, I will do it for everybody. How many of you will do it for everybody? No? Yes. So tell me. Rule out. Yes. So there are certain rules and criteria with regards to this. Please have a seat. One is called as the Canadian C-spine rule. The other is called as the Nexus criteria. Canadian C-spine rule and Nexus, NEXUS, Nexus criteria. To make it simple, any patient who may be more than the age of 65 may not be able to communicate well with you with regards to neurodeficit. See, ये सब जो मैंने dance करवाया है आपसे, that requires a lot of compliance on the part of the patient. If the patient is not compliant with you, well, how am I going to document anything at all, whether he has a neurodeficit or not? So anybody who is more than age of 65, more likely chance of the patient to be disoriented, or there may be accompanying head injury as well. So age is one criteria, more than 65, please investigate. Number two, mechanism of injury. खाली खड़े खड़े फिसल गया, less likely, ऐसा नहीं spine injury हो नहीं सकता, but less likely to have a spine injury, right? So fall from a high road traffic accident, high velocity injury, keep a low threshold to investigate. And number three is paresthesia or neurodeficit. Any patients complaining of mungi yete, hatat payat, not able to move fingers, not able to move feet, you keep a low threshold to do a investigation. Now, what investigation? Easy part. Tell me, क्या करोगे? What investigation will you do? Basic. Which one? Sorry. What radiological investigation will you do? Somebody told MRI, a basic X-ray. What X-ray? Chest X-ray. Spine to be there. What spine X-ray will you do? LS spine. Okay. And for the cervical, C spine. C spine X-ray. The technician is asking AP or lateral. Ideally both. Ideally both. But which one is more important? Lateral view, because it will show me if there is any facet in dislocation, right? Any subluxation, any fracture. So lateral spine view. Okay, I've done the X-ray. X-ray came normal. Does that mean there is no neurological or spinal cord injury? Will X-ray pick up everything? No. So what is my next step of investigation? MRI or CT? Raise your hand for CT. So that's about, okay, that group is very enthusiastic. Raise your hand for MRI. So how's it? The group is against raising their hand. Okay, great. So very enthusiastic. So yes, in an ideal world scenario, I would want an MRI. Why? Because any ligament injury of the spine, and very subtle injuries of the spine, I will be able to appreciate it on the MRI. But will I order an MRI? The answer is no. The MRI will take a good 45-50 minutes on the machine. Maybe my patient will become unstable and die. And radiology department will be panic, what have you done, what have you done? So I would get a CT scan done, which will take less than 2 minutes. That will tell me any major injuries which are present in the spine. And after a day or so, maybe after a few hours, when I feel that the patient is absolutely stable, all other organs are absolutely normal, no other department is involved, it's a pure case of spine injury, that's when I get an MRI done to do my definitive measure. Everybody happy with this? So there's one investigation that is going to help you a lot in spinal cord injury cases. It's a CT scan. It's called as a trauma CT. Fair enough. जो head से लेके spinal cord lower spine तक पूरा scan कर देगा. So what tools are available? We already talked about the Canadian and the Nexus criteria. So in this particular setup, the CT scan was unavailable, which also means that the spine surgeon was unavailable. So what will you do with this patient? So patient is very poor, we cannot afford anything other than us. What will you do? And now patient को weakness है. What are you going to do? You don't have CT scan. Sorry? So we'll buy a new CT machine. So it's very important that we realize that which patients we can manage by ourselves, which ones we cannot. and refer it to the right person, get the right surgeon to treat this, get this patient have a CT scan. Right, so ABCs we already discussed. The patient had further complications, he had shortness of breath. Why do you think that is happening now? Sir, I did everything right, I followed your ABC. How can patient have shortness of breath? He cannot. But he's having now. So what can be the reason? Anybody, why yes? Okay, yes, that's possible. But kabhi ho gaya hota na? And most of these patients, when we are dealing with pons and medulla oblongata and all, most of them don't even come to us. They pass away even before they come to us. So अभी तो मैंने सब कर लिया, patient को shift भी कर दिया, and then why is having shortness of breath? It may not be related to the spine. What is important is that such a high velocity injury, there may be other things that may be happening, and we are focusing on the spine. So there may be some problem with the breathing, there may be pneumothorax, there may be hemothorax, there may be lung collapse. Something that could be happening which could be giving shortness of breath. Right? So we talked about the transfer and C6 and T6, both two factors were identified. So another important thing about spine injury is that once you get one spine injury, there are more than 10% odds for you to have another spine injury at some other level, which you have missed completely. So at least 1 to 2 patients out of 10 will have an associated spine injury other than the injury that you have already seen. So it is very important that once you have identified the spine injury, you're going to screen the entire spine so that you don't miss this 10 to 20% of the injuries. Right? Very clear on that? Any questions? If you don't ask, I will ask. Right. So again, I would like to summarize here that each one of you is responsible for a spine injury patient. You can never say, oh, this is not my cup of tea, it is your cup of tea. Right? Airway and cervical spine immobilization comes as a part of A. We want to deal with this injury later on so that we can deal with airway, breathing, and circulation. All we have to do is immobilize the spine for that period of time. Once those things are managed, we come back to the patient, check for paresthesia, check for neck tenderness, see at the age of the patient, see at the orientation of the patient, and decide whether the patient requires an investigation, whether the patient requires a neurosurgeon or a spine surgeon to look into it. Right? And then probably immobilization can be removed if the clearance has been obtained. Okay? The patient does not deserve to live a life with paralyzed limbs. And that is the reason we want to take this matter very seriously. All right? Thank you. Thank you so much.
Thank you so much, sir. I request Nehal, tutor MGM New Bombay College of Nursing, to appreciate him with a certificate.
Polytrauma. And ये डॉक्यूमेंट पॉलीट्रॉमा yes उसको
So our next resource person is very famous personality in our campus, Lieutenant General Dr. K.R. Sargotra, Hospital Director, MJ Medical College Hospital and Navi Mumbai. He's an orthopedic surgeon and renowned teacher. His services include Professor and Head Orthopedics, Armed Forces Medical College Pune, Senior Advisor Orthopedics, Joint Replacement Surgeon, Army Hospital New Delhi, Director and Commandant, Military Hospital Jammu. So many services, and he was also awarded by our President of India in 2007. So we are glad sir is here with us. I request Mrs. Sarika Sukesh Nair, Assistant Professor, Dr. Punchitra, Professor and Vice Principal, NGM New Bombay College of Nursing, to felicitate him.
Can you hear me? Without this? I think it's better. So it's a big call. Yeah. Good afternoon. Are you all still awake? How many from NGM? Just raise your hands. Awesome. Before I start my talk, I will show you a video, right? And that video is from our hospital, NGM Medical College Hospital. That's an actual video. And let us see, after you see the video, let's see the question answers, right? Okay, start the video. What does it show? It shows a bus which is turned upside down. So, keep seeing this video. And can I control this video from some? I can control. Yeah, I'll control it from here. Yeah, I can do that. Where is the? Yes. Keep seeing. And many of you may be able to see your faces there inside. The date is given on the top if you want to see which day's incident is this. So one ambulance goes, another one comes. This is the actual case scenario. There's no simulation. And this is your hospital. And look at the crowd, the number of people around the ambulance. They are unloading the casualty and taking it to the casualty area. Right? There they go. It is a little faster. Otherwise, this take half an hour. They are not moving as fast. Right? I'll take it a little forward. Okay? This is your casualty corridor. He is getting ready. Casualty. Okay? This is inside. The casualty is being managed. You can find me also somewhere moving my hand, right? Giving directions. I'll close this video. Now, what was this? If you look at this case scenario, if you look at this video, can someone tell me? And if I know someone, some person, I'll ask the question directly. Otherwise, I'll say, hey, you there, answer this question. What is? Can you tell me please? What is this case scenario? This video, what does it show?
Pointer next.
This next. Right. What is this? Doesn't matter. This lady there. Yeah, what is this? Mass casualty. You find one ambulance coming, immediately thereafter another ambulance coming. Doctors inside, outside, the people are taking out the casualty from the ambulance and taking it to the casualty area where the treatment is required to be done. Right? So what is a mass casualty? Next person, what is the mass? She's like, listen. Yeah, next lady. She said it's a mass casualty. I understand it's mass casualty. What is the mass casualty? More than 50. One time, 15. I thought 50. All right, more than 15 people. Yes, how many people? What is the mass casualty? More than? More than? More than 5. More than 5. Okay. In between here. And wild guess word. Any wild guess? Oh, yeah. He knows. Yeah. He is slightly right. He's slightly. When the capability of that particular center exceeds the management of the number of patients which it is normally doing. How many patients we manage in the casualty at a given point of time here? At a given point of time, not in 24 hours. 24 hours we'll do 60. At a given point of time, how many patients can we do? 3 patients. 3, 5, 6. That doesn't make it mass casualty. When it exceeds the capability, it could be 8 casualties coming at a given point of time, becomes a mass casualty. It can be 10 casualties coming at a given point of time, becomes a mass casualty. So if it becomes a mass casualty, then middle person. Then what should be done? Mass casualty is coming. Mass casualty, the resources given at that point of time in that casualty will not be able to manage those patients. Is the definition clear? Mass casualty means the resources there in the casualty at that given point of time will not be able to manage those casualties. So that becomes a mass casualty, right? So if the mass casualty occurs, what should be done? To activate the identifier. What is that called? Anyone, what is that called? What is that called? Is it, yeah, what is it? What is that? Somebody said, right? Somebody said. The one person at a time. What is it? Right? What is that? Code. Which code is this? Code orange. Code orange is it? Like your code blue, your code pink. This is whenever the mass casualty comes, what do you have to do? Code orange. Code orange is a SOP. It's a standard operating operation procedure that if there's a mass casualty, you do this, right? And okay, yeah. Can you tell me main features of code orange? Who has not seen the code orange in this hospital? Can you raise your hand? Who has not seen code orange? We get minimum twice in a month we get mass casualties in MGM. Therefore, majority of you, if you keep your eyes open, you will find a mass casualty incident, which is called MCI, mass casualty incident. All right? So what are the major things in MCI? Major things in Code Orange. Can you tell me what is the word? I'm just beginning that discussion. Then I'll go on to my PPT and tell you more things. Right? Code Orange means if you saw this incident, you require more doctors. You require more doctors. You require more nurses. You require more housekeeping. You require security. Right? So you require surgeons. You require orthopedic surgeon. You require a neurosurgeon. You require a thoracic surgeon. You require a EMS specialist, emergency specialist. You require a trauma. Therefore, you will require more doctors, but more specific doctors. Do you require a dermatologist? No, not. Do you require a psychiatrist? Maybe sometimes the person can go this way, you may require. But these are the people who are required. So there will be a MCI, mass casualty incident, and there will be a incident commander. Commander is the army word. Commander is not a. So there will be an incident commander. Under that commander, he'll have the doctors, he'll have the nurses, he'll have the housekeeping staff, there will be security staff to man. You saw the crowding outside. They will not allow you to manage the patient inside and they create so many sorts of disorders, drug conversion, and so forth. Therefore, security is very important. All right. If you have done this, right, therefore the message has gone to all these people. Through the hospital director, through the medical director, through the dean, through the nursing superintendent, the message goes. This aspect, right? The message goes, then these people start coming. There are two things. Either you get the pre-information. Pre-information is that there is a bus accident on the Bombay-Pune Express Highway and you get a call. There's a bus accident and you get, they may say 15 casualties are coming or 30 casualties are coming. There was a bus accident near Khopoli and the 40 children came to us. But we got the news that 40 children are coming. The advantage is that you get preparatory time. What is the preparatory time? I said the manpower. Then what else? What else? Yeah, this thing. Wait a minute. Yeah. What is process? Very good, very good. All of you know. You are working in medical college, you know. What is process? You require X-ray department to be activated. You require access to dirt CD to be done, or maybe rarely MRI to be done. You require lab, or investigation to go to the lab. You require pharmacy, because medicine may be required, will be required. Blood bank, which is blood bank? 100 by 100. So all these services have to be activated, right? You require manpower, that's a resource, and you require resource services, which are very much required when a mass casualty incident takes place. So this has happened, mass casualty has happened, the patients have come, you have the resources. Now how to utilize those resources? One is incident commander. Who's the incident commander? Usually he is either a general surgeon, madam has come, she is here. Either it's a general surgeon or it is a trauma surgeon, right? Or it is an emergency medicine specialist, because the incident commander. Somebody has to control, otherwise patients are coming, who will manage? And I think you all been learning A, B, C, D, E, right? Therefore, a bed has to be reserved, right? For the, okay. What is the classification of these patients when they come? This is triage, right? Now somebody will tell me what is, because when the patients are coming, you don't know whether this patient is serious or not serious, whether it requires treatment, doesn't require treatment, whatever. What is triage? Who can tell me what is triage? Anyone? It's a French. Yeah, that's you were put in the pocket, right? Yes. Yes. Triage. partially correct. So triage means, what exactly triage means? Triage is basically a word which is sorting out, right? Sorting. Right. Good. Very nice. So what are the kinds of? So what is that called? Immediate care. Very. What is that called? P1. Priority one. Right. Becomes red. Okay. Priority two. So what is the color for? Yellow. Priority three. Green. Priority four. Black. Normal. So we got priority one, priority two, priority three, priority four. And the color coding is red, yellow, green, and black. What is black? What is black? What is black? No, both. Either dead or dying. It's both. कुछ सांस आ रही है और नहीं आ रही है. It is both dying or dead. Is black and it is P4. So you got P1, P2, P3. Who can tell me what is P1? Now you sit down. Enough. Who can tell me what is P1? Priority one. What is priority one? Yeah. So how will you know this is priority one? So there, please remember that there is a station called triage station, right? And if you go to our calendar, on the left hand side, you put up the station, and they got those ribbons, right? They got these ribbons. If you tie on this net, that's I tie it from the on the wrist side. They got the red, they got the yellow, they got the green, and they don't have black, right? Black is not an issue. Okay, what is priority one? Patient head injury is priority one. Okay. Yes. What else? What else? Chalo. The lady is very in this group now. Anyway, you are four. What is priority? It's important because priority one will go to red bed, right? Priority one. Good. Any patient A, B, C compromise. Very simple. Airway, breathing, circulation compromise becomes P1. In other words, patient requiring immediate resuscitation. What is it? Patient requires, because if the patient ABC is gone, patient requiring immediate resuscitation becomes P1, right? What is P2? What is P2? It's P1. What is P2? Unfortunately, you can only ask questions to people sitting in the front. Yeah. What is P1 is the patient requiring immediate resuscitation. Maybe oxygenation, maybe intubation, maybe putting in a chest tube. What is P2? Patient who does not require immediate resuscitation but requires treatment and requires surgery later, but does not require. What are those? Fracture, yeah, usually fractures, right? Listen up. P1 immediate resuscitation, P2 usually fractures of the long bones, and what is P3? P3. This classification is from the armed forces, right? Armed forces, but it is that this is in applied to the civilian situations now. What is P3? Anyone? Yeah, second row. What is P3? Yeah, you know it, I know you know it. He says what is not P1 is what is not P2 is P3. So, जो P1 नहीं है, जो P2 नहीं है, P3 होना है. इसमें कोई doubt है क्या? इसमें कोई doubt नहीं. You see, this is called this is walking wounded. Again, walking wounded is basically walking wounded means बेचारे को चोट लगी है और चलता चलता आ रहा है. So P3 is walking wounded. So this triage is French sorting out. Priority one, immediate resuscitation. Prior to immediate resuscitation not required, but immediate treatment. P3, walking wounded or whatever the like you said, whatever is not P1, what is not P2 is P3. What is not P4, right? P4, as I said, is a dying patient or it's a dead patient. Because dying and dead patients take the last priority, P4. Because if you start not here in this situation, if you start resuscitating a dying patient, many patients whose lives can be saved will get compromised. So, right? Now, here is the, now here we are the patient. Now, patient is P1. So, what should you do with the P1 patient? There will be a P1 bed, there will be a red bed, right? In fact, basically, there should be a person who can look after the airway. Who can look after the airway best? Who looks after the airway best amongst all the doctors? Who looks after the airway best? Otherwise, you know, you got a red bed. One doctor also is coming, second doctor also is coming, third doctor also. They are fitting on, they fitting on, but the organized method of management of patient is not there. Who looks after the airway better? No. Anyone who looks after airway amongst all the doctors? Anesthesiologist, A for airway, A for anesthesiologist, right? It's similar. So therefore, A should be on the head. Suppose this is dead, A should be on the head, let's say. Right? Here. And you should have a band here. Anesthesia, whether resident or not resident. It should be there so that people can recognize, oh, he's still come on the head side. Okay. What is B? Who? B is फिर आप बोल रहे हो अभी मेरे पहले वो डॉक्टर साहब आए थे वो अच्छे से बता के फिर आप ब्रीदिंग बोल रहे हैं ब्रीदिंग है who's the right person who can look after breathing and ventilation? Respiratory, yes, but usually respiratory does not come here. Usually the general surgery, right? Because they may require to be put in a test tube. Okay, so if you want to look after A, you look after B, and who's the right person to look after C? Again, in the general surgery, that is why he becomes the big member, or he becomes the incident commander, right? And now from the general surgeon, they have taken it, given it to trauma surgeon, trauma and specialty, right? They are taking the initiative from the general surgeon, madam is sitting in, she's like, I want to do this procedure, I want to gap for it, I want to do this, is it doesn't matter, you keep doing all that. The emergency initiative will be taken out from you and will give it to the traumatology surgeon, the new specialty is coming. All right. So when the patient goes to the red bed, patient is now don't tell me who will intubate, who will put the two white book cannulas, right? And then further management. Keeping this scenario in mind, I will show my PPT. In that, can somebody tell me what is a multiply injured patient? Anyone? I'll be very happy. What is the, now these patients came, but you can't hear that. What is the multiply injured patient or what is called, it's in polytrauma. Somebody said me. Okay, go. Who said that too? Very good. Two or more than two organ systems. Please sit down. What are the organ systems? Head is organ system, chest is organ system, abdomen is organ system, pelvis is organ system, long one organ system. Two or more than two. But seriously, right? Not that having to do with GCS of 50 doesn't make it a multiple. Has to be seriously injured two or more than two. Less than least is two or more than two becomes a multiply injured patient. Now let us see what are the priorities in the management of patient who's got multiple injuries. Yeah. Let's read it here. These guys can be switched off so that the screen becomes clear. Yeah. Polytrauma or polytraumatized patient is a subgroup of injured patients who sustain injuries to more than one body more than one, more than two, with at least one of the injuries be life-threatening, then it becomes not simple injury, right? Polytrauma means a syndrome of multiple injuries with systemic traumatic reactions, which may lead to dysfunction or failure of remote organs and body system. Failure of remote organs. What are the remote organs? Failure of respiratory system, failure of liver, failure of multiple organ system failure, right? Again, polytrauma. Needs management by a team of surgeons and physicians. I said that we require teams of surgeons and physicians. Orthopedic surgeon is one of them, right? Orthopedic injuries are generally not life-threatening. What are the life-threatening injuries? We have a neurosurgeon here, head trauma, killer, right? Chest trauma, abdominal trauma, pelvic trauma. Worldwide, number one cause of death amongst the younger ages, 18 to 44 years, because they are the active people, they are driving, they are going on vehicles, they are actively involved in the all the jobs. So therefore, worldwide, number one cause of death amongst the younger is the polytrauma, right? Third most common cause of death in all age groups. Therefore, that is the importance of polytrauma. Number one killer amongst the young people, right? And number three killer, all age groups. Polytrauma is not a surrounding with, I said that it's not multiple fractures, it's not polytrauma. Polytrauma is two or more than two organ systems seriously injured. Multiple fractures are not purely orthopedic problem, as there is involvement of skeletal system. While in polytrauma, there is involvement of more than one system, like especially with head injury, chest injury, spinal injury, abdominal injury, or pelvic injury. Now, let's see how the death takes place in polytrauma. Why is that important? Immediate trauma death, first peak. I will show you a graph. First peak, right? Early trauma death, second peak. Late death, third peak. This was given by Turnkey. He was one of those initial trauma specialists, general surgeon. First peak of death, first peak. Polytrauma, first peak, right? Severe head injury. I said that. We have a neurosurgeon sitting a severe head injury. He also had also severe head injury. Patient is going to die. Brainstem injury, part of the head injury. High cord injury. The speaker before me was talking about the spinal cord injury, and he said the high spine, cervical spine injury is very, very dangerous. Heart and major vessel, once the heart is injured, major vessel is gone, aorta is gone, very little chance. And massive blood loss, more than 40 to 50% of the volume. That was the first thing. This is the second thing. Intracranial bleed can be treated if the patient comes on time. Chest injury can be treated if the patient comes on time. Abdominal bleeding, pelvic bleeding, multiple injuries. Third peak. First peak I said that. Second peak, this is the third peak. Third peak is patient is lying in the ICU. You put one line here, one line there, one catheter here. He goes into sepsis, right? And then the patient dies. Third peak. Now this is the turnkey DD. This was as early as 1983. This is the man who is credited with the management of polytrauma, initial management of polytrauma. So this is the first peak, 50%. Death on the spot. Nobody can do that. Why? Because I said the first peak. Those were the reasons. Massive head injury, run over, crush injury. For whatever you do, this probably becomes non-treatable. It happens in minutes. Now this is what happens in hours. Second peak here, 30%, 50%, 30%, 20%. 50%, no chance. 30%, brain, brainstem, aorta, spinal cord, heart. Now this is the epidural, subdural. Now this is where you can retrieve the patient and the patient can be treated. and the remaining 20% is the patient dying in the ICU. That is how the golden hour concept came into this thing. Because patients are dying in the first hour after the injury. Therefore, if you want these patients should survive, the treatment must go in the golden hour. The first 60 minutes after traumatic injury has been termed as the golden hour because these patients may be safe if the rapid assessment and management of the injuries is done. But in this golden hour, there's a platinum 10 minutes where you got quick examination, quick treatment, and quick transfer. Aim in management. To restore the patient, the aim of management, of course, is that the patient must go back to what? Suppose he was a cricketer, he should go back to cricketing or whatever he was doing previously, pre-injury level. Now, these are the priorities. First is limb salvage. Second is life. What is the life of? Sorry, life takes over limb, takes over total function if it is possible. So first is the life, save limb, and then salvage whatever function can be salvaged out of the patient, particularly the patient. 50% deaths, we said, occur before the patient reaches our hospital. Our hospital are anti-vaccination. Those are the first 50, the first thing, right? 30% occur within 4 hours of reaching the hospital. Now, this is what the hospital should say. This hospital can't do anything. These patients are going to die regardless of whatever facilities you have. You have a massive transfusion, whatever, because they don't reach you. They don't reach the hospital, they die on the spot. You see a bus accident, so many patients dying on the spot. All the patients, more or less, cannot be saved. This 20% I said, they die in the hospital because of the sepsis. And then if preventive measures are taken, 70% deaths can be prevented, meaning 30% deaths are non-survivable. This I said, general surgeon, from the general surgeon, of course, this has been taken by the trauma surgeon, orthopedic surgeon, neurosurgeon, sir is sitting here, thoracic surgeon, because the chest trauma is there. We have a thoracic surgeon also here. Accident emergency medical officer, not surgeon, urologist, the urogenital injury, and then anesthesiologist, of course, the person who manages the airway. Now this you've been reading, ATLS, advanced trauma life support, the person speaking to me before me was emphasizing on ABCD, right? Now first is the primary assessment, right? What is assessment, the primary assessment? Yes. Airway. फिर आधा बोल रहे हो ना वो बेचारा बता के not बेचारा the previous doctor साहब he was a born surgeon probably only surgeon he was must be surgeon the previous surgeon airway with spinal any number of times you repeat you will learn better airway with spinal mobilization, right? Otherwise neurosurgeon is sitting here you can gun and shoot you if you don't mobilize the. If you don't immobilize the C-spine, you will have a quadriplegic patient. Can happen, right? Second is what? Oh, okay. A after A, breathing and good. In chorus. C and stoppage of breathing. D. Disability means CNS, right? E. Exposure, right? E, F. Stop it. F is going to treatment. It's not that you've done it once and then left it there. No, you keep managing and do treatment, right? Okay. Who will tell you this secondary survey? You must have heard this terminology right from since morning. What is secondary survey? Yeah, head to toe examination. After the primary survey and the primary assessment is over, the patient has been stabilized, then you go. When the patient is stabilized, is not stabilized, you don't go for secondary survey. You do the primary survey and simultaneously managing the ABCG, right? And then this is the F I was saying, constant revaluation, very important. Initiation of definitive care, of course, will take place. Pre-hospital, extremely important. If the pre-hospital care is good, you will save more people, more casualties than any super specialist can save. Pre-hospital care is extremely important. In that, very simple. We said airway, cardiopulmonary resuscitation, fluid replacement means doing a lactate, maximum of the 2 meter, reduction and splinting, not reduction, splitting of fracture. You can't reduce the fracture because you have to split the fracture. Perform primary survey of the patient, like we discussed it. We discussed enough about triage, right? I'm not going to dive more on this. Golden hour. Okay, we read about golden hour. Tell me what is it. Why is it called golden hour? Yes. If it, within that hour, first hour, if appropriate, adequate, right treatment is given, many lives, not all, but the many lives will be saved. That's why it's called golden hour, and then I dilated on the platinum 10 minutes also. Once more, right? Because I remember that time you read about this. This is the crux of saving lives. I know the feeling or immediately in the tell you. Just read it from. Yeah, just read it from. Loud.
Airway with six-point control.
Yeah, airway with 6-point control.
Breathing with ventilation.
Yes,
Circulation with anesthetic control.
yes,
Disability with neurological status.
yes.
Exposure and abundant control.
And
F was frequent.
frequent is very important, right? Now, primary survey, I'm not going to repeat because we learned enough about it, and since morning we're learning about this. Same things, primary survey, in you want to look at the area obstruction. Why not in that area obstruction? Second is the major causes of problem are tension pneumothorax, open thoracic and plain chest. Can somebody tell me what is plain chest? Plain chest. No, more than 2 ribs at 2 sides. If they are fractured, that segment becomes flayed, and the whole physiology of respiration goes ulta, paradox. Cardiac tamponade can kill the patient, massive internal or external hemorrhage. These are the signs of airway obstruction. Somebody must have taught you, look, listen, and feel. And then, airway cervical spine, we talked about it. When to ventilate? There was one situation when he said the patient is not breathing, you ventilate. Ventilate means you intubate. That is the definitive airway. Now, these are the situations. Apnea, patient not breathing. Hyperventilation, plain chest, high spinal cord injury, like the previous speaker was saying. Diaphragmatic injury, same. High cervical spine injury, C3, C4, C5 got diaphragmatic paralysis, so chances of respiratory arrest. ECS, less than 8 or less than 7. Hypocapnia, which you know hypocapnia, hypothermia. I need not direct on this. Maintenance of airway, simple. Look at the airway first. If it's not patent, then you suck, then you clean, and then if it doesn't happen, then you put a mask, and thereafter you can do endotracheal intubation. If all that doesn't work. Now these are the places where the major bleeding can take place, and you have to look for it. Where can the major bleeding take place? Number one, the external bleeding from the long bones. Number two, major bleeding cannot take place in the head because it's a small cavity. It can take place in the chest, abdomen, pelvis, lump, right? Cause of major bleeding. If it is external bleeding, pressure, right? Maybe sometimes tunic. What is the tunic called? Cat. Can anyone tell me what is this cat? It's not black cat, white cat. What is this cat? It is combat application technique again. The word has come from combat, right? Combat is armed forces. Thoracic bleeding, what do you do for thoracic bleeding? I see, Varun is already sitting here, right? Pelvic bleeding, you put a fixator. Or you do put the binder. Intra-abdominal bleeding, you have to operate, no other way. Patient is taken for the emergency, laparotomy, long bone fractures can be fixed or splintered. Classification of hemorrhage, somebody will take this, my legs are too long. Do I have some more time? 2 minutes more? I don't know, I haven't seen the watch. Somebody can watch me. If time is there, then I can continue. If time is not there, then I'll try to. 5 more minutes, 5 more minutes, so that's good. So, hemorrhage, it is clinically classified into 4 classes, right? Class 1, class 2, class 3, class 4. Class 1 hemorrhage is 15% blood volume loss. How much is 15%? 1 liter? Little less than 1 liter approximately. So nothing much happens. Very tachycardia will take place, right? Treated with 1.5 liters of renal actin. Class 2, 15 to 30% of blood volume is lost, and then again 1.5 liters of renal actin. Class 3, 30 to 40% of circulating volume is gone, that means almost 2 liters is gone, and then this can help, go into erection into hypertension, 2 liters of supply. Now you start getting, what do you activate at this point? For class 3 and class 4, what do you activate? Massive transfusion protocol, MTP, for class 3 and class 4, right? And then when you go to class 4, you will require FFP, you will require platelets, in addition to fluid resuscitation and giving blood. Neurosurgeon is always sitting here, in this screening after me, he'll dilate it on it, right? Neurological evaluation, 50% of trauma deaths are due to head injuries, 50% of the deaths are because of head injury. To describe the level of consciousness, this is ADPU is very, very rough. You all should not continue with this. Now the Glasgow Coma Scale is the one which is followed, and this is the Glasgow Coma Scale. Normal is 15 by 50, anything less than 10, you got to be very, very guarded, very, very careful, right? And this is this you all know. You know all this, right? Eye opening 4, verbal response 5, motor response 6. And if you can't remember this, keep the card in your pocket, right? Take out that card and then see it and then write. Extremely important. This is objective. That ADPU was not objective. With chest injury, we said it's a flared chest, ventilation, if it is pneumothorax, chest tube. Now these are the adjuncts to the primary survey. You have to do ECG, urinary catheter, maybe the right tube, C-spine lateral, chest X-ray, pelvic film, essential X-ray. These are required to be done in the emergency when you are doing the ABCDE. Secondly, survey, some lady got up from there and said, examination right from head to the toe after the patient has been resuscitated. Life-threatening orthopedic injuries, I'll skip over most of these things. 0 hour fixation is fixation when the patient comes. Usually it's not done, but can be done. Fixation of fractures when the patient comes. Transport, splint, and transport. Now that's how the log rolling being shown. You require at least 1 on the head side and 3 on this side for the log roll, especially in a spinal cord patient. Pelvic injuries can cause shock, and then this requires, what do you do for pelvic injury? Pelvic binder, or you can put a external fixator, or you can do pelvic packing if the patient is still bleeding. And this is one of the external fixators which you must have seen is been done as an emergency measure in a hospital. This I will not go in detail, it's the same thing. First hit, second hit, same. The first I told you initially. Now, this is one of the things you want to remember. The serum lactate levels can show you the range of mortality. Polytrauma must be considered as a systemic surgical disease. Number one, primary objective is survival of patients. Early fixation of major fractures after surgery is available. With the right concept has proved to be an important tool to obtain this primary objective. Now I think right. So much so I have explained. I made it interactive initially, then I started speaking. Now, any one of you want to ask any question? Or shall I ask? I'm not asking questions. Any questions? Oh, good, great, yeah. If you have it,
Dying patient.
done.
And very technical.
Yes.
Yeah, how can we decide which is important? Means, is dying patient's life is also important.
Excellent question. Please, please. I know nobody will ask this question, I will ask it. Dying patient, when I was giving an example, I was giving an example of a large surgery operation where the patient is dying, the resources are limited, and then we're not paying for it. But here in this situation, dying patient has got to be paid. Dying patient is not paid in a situation where you got 10 more people whose lives can be saved, and this patient takes the last priority because you don't want to put all your resources there and then compromise with these 8 or 10 patients. This patient who is dying requires as much attention in a peace area or in a peacetime or in a hospital as much as others. Right? How much attention? As much attention as the human being. That situation, what I said, is great in the battlefield. It's not here. And all this P1, P2, P3, P4 is picked up from the battlefield. Nobody is getting it. Civilian, I'm not civilian, I'm not civilian. Right. This is picked up from the surgery has evolved from the battlefield. Whether it was World War I, World War II, let's not talk about World War III, this will close the day. Surgery has evolved from the World Wars, right? So therefore, those long pages have to be taken by the civil court. That's how it is. If there were no war, surgery would be. I'm very sure about it. Now the surgery is going the robotic way. It is going what are the way? Navigation way. Sorry. Yes, any question, any more questions? Thank you so much.
Thank you so much, sir. I request Mrs. Sarkesh Nair, Assistant Professor, MGM New Bombay College of Nursing, to appreciate him with the certificate.
Getting certificate is. Good. It's like a director. Don't stand there only. Otherwise, you won't get the certificate.
For the next session, we have Dr. Disha Suraj, Professor, Department of Surgery, MGM Medical College Hospital, Navi Mumbai. I request Ms. Poonam Rane, tutor, MGM New Bombay College of Nursing, to felicitate her. And this pointer, this. Good afternoon. After this excellent talk by sir, I'm a bit nervous to deliver my talk. So I will be talking about the abdominal and the pelvic trauma. That is a serious killer. And as sir told already, this is something which we can prevent the death. The abdominal and pelvic trauma, the people are salvageable. You act in time and you can save many lives in these cases. That's why it's very important. You have to diagnose it and treat it in that golden hour or whatever it is, as soon as possible. Coming to the classification of abdominal trauma, there are many types. Mostly it is the blunt trauma, the penetrating trauma, and the iatrogenic. The iatrogenic is something, I hope you all know what is iatrogenic. It is something caused by some people. So when we talk about the abdominal trauma, the iatrogenic also carries major changes by that also. The blunt and penetrating trauma is like the other like RTAs and all those history fall and all those things. So in the blunt trauma comes the crush injury, the blast injury, and the seatbelt syndromes. Very important cause nowadays because seatbelt is a must. The RTAs are increasing nowadays, and many people get crushed because of the seatbelt, because that doesn't expand. Your airbag will come and the seatbelt is there, and that impact causes a lot of trauma because of the seatbelt. Second is the penetrating. Anyone who is any penetrating injury, anything, maybe glass or some instrument or some knife or the gunshot, all these things come in the penetrating wounds. And then comes the iatrogenic, which in many cases go unnoticed or unreported. Only the treating surgeon or the person who caused it only will know, but that carries a big chunk. Nowadays, with the advent of a lot of laparoscopy surgeries, endoscopy surgeries, we get a lot of iatrogenic injuries, and things are like endoscopy. Endoscopy surgeries, when they put the endoscope, and there are a lot of surgeries being done through the endoscopes. Not very common, but still it is being done. So when they do that, they can injure the bowel or the esophagus or the stomach, and that may go unnoticed. Second is the external cardiac massage, not being done very commonly nowadays. Peritoneal dialysis. Peritoneal dialysis, they put a catheter inside the peritoneal cavity. You all know that. During putting the catheter or the catheter itself, when it is lying down for a long time, it can erode and it can damage a part of the bowel, and many people won't even come to know about it, and unless it causes some peritonitis and all that. And then percutaneous transhepatic cannulation. That's a very common thing which is being done nowadays with the intervention radiologists or with mainly the intervention procedure. So when the liver is, as you all know, it's a very vascular organ, and we are putting a catheter inside the liver, and that can damage a blood vessel and that bleed voraciously, which you cannot stop. And people can die, especially when you're having tumors, which are salted lesion in the liver, which may be a malignancy. You're taking a biopsy, you will injure the vessel, and that bleeds, and that can even lead to death of the patient. Another thing is like hemangioma in the liver. Hemangioma in the liver is like vascular malformation in the liver. You put a needle inside that, and you can see it bleeds like it's a severe bleeding which we cannot even imagine. Okay, we have to take the patient in, open that, and try to control the bleeding, and they may even end up with a hepatectomy or a lobectomy and all those things. Then the same with the guided liver biopsies. So any intervention before you plan intervention, they all look very fancy. You're not cutting the patient. You're doing with a small tube or with a needle, but they all carry their own
chunk of complications, okay, which in many cases go unnoticed and unreported. Next, coming to the abdominal trauma per se, we can divide it into solid organ injury. You know that in the abdomen we have a lot of things, lot of things. Solid organs mainly are the liver, your spleen, and your pancreas, and what else? These are major three things which we talk about: liver, pancreas, your spleen, and your kidneys. They are the solid organ. The hollow viscous is like starting from the lower end of the esophagus, your stomach, all your bowels, your colon, your rectum, everything come in the hollow viscous. Then comes another important structure, that is the retroperitoneum. Why the retroperitoneum important? Anybody has any idea? We talk about the retroperitoneal injuries. They are very, very risky stuff. They can claim the life. Why that is important? Retroperitoneum. That carries all your major vessels. Major vessel like aorta, your inferior vena cava, and your iliac vessels. They are like situated in the retroperitoneal region. Okay. And then comes the diaphragmatic injury. Diaphragm is something which separates your chest from your abdominal wall. If the diaphragm is injured, what happens? The thing which is supposed to be in the abdomen, that goes into the chest wall. So your lung is compromised, the patient cannot breathe, that can kill the patient. So that is a classification, and there are some pictures here shown. They are not real life pictures, but you get something like this. Blunt abdominal trauma, somebody is hitting the tummy, and you might think like, okay, maybe for fun, or nowadays with a lot of people going in the gym, they have all the biceps, nice, big biceps. A small blow on the tummy even can injure the liver or your bowels or your spleen, okay? And this next is the second one is shown as a crush injury. Crush injury is the same way, like you're being hit by a moving vehicle, or you're just falling from a bike, or fall from a height or something like that. And you get the patient just come with something like this, and there can be some erythema or some reddish coloration on the abdomen. And these all things has to be taken very, very seriously. Like when you examine the patient, you are resuscitating, then there is something called a primary survey. I'll come to that later. Secondary survey and all that, and you cannot miss all these things. Okay. So somebody who's sustaining a road traffic accident, because nowadays all the vehicle, like when the four-wheelers, they should be having seat belts in all the seats, and this is how the patient comes in. Can you see that mark on the seat belt? Okay. So you can't miss all this thing, and you have to suspect an abdominal trauma, investigate and treat the patient. Then penetrating trauma, there is nothing like patient will become with the bleeding or some knife over there, some iron rod. We get all sorts of patients over here, or iron rod, patient falling from a height, some iron rod going in the body. Recently, we had a patient who had a rod. A few of us have heard of that, and the patient was in the ward, which went from the neck and came out through the chest wall of them. The left side is gone, and the right side. The patient was revived, and he went home nicely. Okay. So these are the type of injury you get in the penetrating trauma, not only in the abdomen, chest, neck, anywhere in the body. And then comes the gunshot injury. Gunshot injury, there will be something called an entry wound, and there may or may not be an exit wound. If the bullet is going out, you get an exit wound. If it is staying inside the body, you won't get an exit wound. But the inside the input that area you will be seeing. And it's a very tricky wound, this gunshot injuries. The bullet will go from one area, but you will retrieve it from somewhere else. Then any trauma patient, this already sir has gone through elaborately, so I'm not going into the primary survey. It's gone to the ATLS protocols. I hope you all know and must have read through that. And adjacent to the primary survey, these are things also are important in case of an abdominal trauma. Like you have to connect the patient to an ECG monitor. You have to put a urinary catheter. If you're suspecting a big or a serious abdominal trauma, a Ryle's tube is a must. Because the moment you see abdominal trauma, these are things which we ask for. Bring a catheter, bring the Ryle's tube, because the patient need to be from all the orifices, whatever is possible, but a tube inside. And the patient need to be monitored. The pulse oximeter need to be connected, BP monitor to be connected, and ABG. ABG, I hope you all know what is it. It's a very common term nowadays. It's the arterial blood gases. Why we are doing the arterial blood gases? I think sir mentioned already in his, the last slides. We need to know how much is the oxygenation of the patient, what is the PO2, what is the PSCO2, and most important is the serum lactate levels. How bad is your patient? Whether we can save him or is he really in a bad condition? So serum lactate is a very important thing nowadays coming up, you need to know about the serum lactate levels, which we can get by just doing the ABG. In 2 minutes, you are the recovered. Okay, next is you need to get your X-rays. Yeah. When we have to do, because we are not dealing with the abdominal injury alone, there may be some other injuries like chest injury, where you will need to rule out a pneumothorax. Okay, the patient is having a breathing difficulty or suspecting a pneumothorax. You can put in a ICD blindly also, but if you are time permitting or nowadays with the medical legal stuff, you have to, like the patient is not that bad, you have to first you need to have some proof in your hand that the patient has got a pneumothorax. It's not possible like everything goes very well all the time. Like you have a patient who is having suspected pneumothorax, you put in an ICD, you can, because the ICD insertion also comes with a lot of complications. You can injure the lung. If you're putting on the left side, if the scan inadvertently, or if you're not a practice person, you can go into the heart, it can injure the spleen. Okay, so you need to have proof in your hand the patient already had a pneumothorax, is in a bad condition. And nowadays we have that all portable machines. You can get the X-ray in a minute. So the chest X-ray is very important. You need to get these things. And X-ray of the pelvis, roll out any pelvic fractures, and C-spine. Okay, so with all the technology coming in, these are all not that difficult also. These are the adjunctive branches. And there is something called a DPL, which is going obsolete nowadays. Like not many people are doing in DPL. What is the DPL? It's a diagnostic peritoneal lavage. Like we lavage the abdomen. We used to do it in the earlier time when the USG is not very common and the CT is not very common. But the DPL is just losing its glory nowadays, and not many people are doing the DPL nowadays. Okay, and the next important thing which we do when we talk about the abdominal trauma is a fast scan. Fast scan is a must nowadays, because why we are doing a fast scan? Yeah, to see whether there is any free fluid in the abdomen. So what are the common areas we look for? We see the perihepatic region, we see near the heart, to see, look for any. What we see near the heart? Any fluid near in the pericardium, because there can be some injury to the heart and there can be some blood inside the pericardial cavity. Even because of that, the patient can go into shock. So it's a part of the fast. And then you see for the fluid in near the spleen and something in the pelvis. So you know that there is some fluid in the pelvis near the liver, near the spleen, near the heart. Okay, you know what you have to do next. Okay, so fast scan is a must. You can't avoid that, because if you have a good casualty, these things should be there in hand. You should have a portable X-ray machine. You should have a USG machine, and the fast. Almost everybody is in the trauma department, emergency department, surgeons, everybody is trained for that, and they have to do it fast, which can be done hardly in 2 minutes or 5 minutes. Then comes the secondary survey. That's again according to the ADLS protocol. It's been already talked by so many people, so I'm not going into that. Then coming to the physical examination of a patient with abdominal trauma, the most important thing is the inspection. I already showed some pictures. You cannot miss all these abrasion, contusions, and laceration. Any crush injury, any change in color, any black color or any white color, whatever it is, you cannot miss that. That will guide you, or that will show you like whether I need to intervene the patient or I can just pass it on. Second is the palpation, not very important, but you have to touch the abdomen and see. Superficial palpation, deep palpation, you have to elicit the tenderness, any guarding or any rigidity. Why this thing is important? Guarded and rigid abdomen in abdominal trauma. Yeah, I hope you all know what is guarding and rigidity, right? You touch the abdominal cavity and it looks really something like a ball. That is called guarding and rigidity. Why is it important? Somebody coming with an abdominal trauma, the abdomen is guarded. We tell, shift the patient. I don't need any other investigations. Why? Because the abdomen, it's containing all the bowels and the solid organ. So any fluid in the abdominal cavity, if it is a free fluid like serous fluid, it may not cause rigidity and guarding. There will be just a distension of the abdomen. But just think like any part of the bowel is injured or some bile is leaking out, that will give rise to peritonitis. Okay. Anybody who is having mild peritonitis also, you will feel the abdomen is guarded and it will be rigid. And some free fluid like blood, even the hemoperitoneum, that can give rise to a guarded abdomen. So you have to touch the abdomen and see whether the abdomen is soft, and with as surgeons, we keep on touching the abdomen like, but anybody and everybody, let the patient come to casualty or when you see, just touch the abdomen and you can make out the difference between a soft abdomen or a guarded abdomen. So anybody with a guarding, even if somebody is going unnoticed, you can like tell them like this abdomen is looking, this tummy is not looking okay, it's looking guarded. Probably he need a emergency treatment or emergency laparotomy or must be some bowel or viscera or some small abdominal injury. So that can happen with the hemoperitoneum as well as with the peritonitis. Okay. Then the next thing is like percussion, where you get a dullness if there is a free fluid, any free fluid. But you need to have some minimal amount of fluid for you to get this for you to elicit the percussion, starting from 500 ml, 1500, 3000, like that. So there should be a lot of fluid for you to elicit the percussion. Auscultation, absent bowel sounds is a very important indication that the patient has got peritonitis, but that is a very late finding. It won't come in the early stages. So, but the inspection, palpation, these two things are very important when you have a patient with abdominal and pelvic trauma. And this is some signs which when we talk about in case of abdominal trauma, sequence sign, I already told you. You have something called a Gray Turner sign, you can see over here. Gray Turner sign is like a bluish discoloration in the lower flank and the lower back, and that is mainly associated with the retroperitoneal bleeding. Retroperitoneal organs we talk about is one is the pancreas, you have the kidney, and any patient with a pelvic fracture or any major blood vessel is injured, you get something like this, the Gray Turner sign. Okay, so there will be if you notice something like this, it sensitizes you like, okay, there is something gone wrong in the retroperitoneum, and which you cannot ignore. Okay, and then there is something called a Cullen sign. That is a bluish discoloration you see around the umbilicus. That again indicate a peritoneal bleeding. Like there is some peritoneal, like there is blood which is collecting inside the peritoneal cavity, and that gives rise to this type of reddish or bluish discoloration, and that is very common sign. This sign, okay. And there is something called a scrotal sign, where you have a pelvic fracture, and you can see because the lower abdomen and your scrotum and the labia region, it is all connected. So when there is a blood getting collected in the pelvic region, that seeps out into the scrotal region, and you are seeing something like this, think of an ongoing bleeding over in the pelvis region or in the scrotal region. Okay, so the scrotum is anyway connected to the pelvis. So if you have a crush injury or some trauma in the lower abdomen, this is also something which you cannot ignore. So these are the three signs, but this Gray Turner sign, Cullen sign, it is seen in some other condition also, not only in trauma. That is called hemorrhagic pancreatitis. Even in hemorrhagic pancreatitis, where you have a bleeding with the pancreatitis, you can see these signs. It need not be always, but in a patient with a history of trauma, look for this sign and you know this is the type of bleeding you expect. Then coming to the investigation, I already mentioned, FAST scan is a must. X-rays, you need the X-ray of the abdomen and the chest and the pelvis, if possible. Otherwise, you can skip it. And CECT is not a must in all abdominal injuries. But suppose the patient is stable, because I already spoke to you regarding the medical legal implications. Nowadays, like you have to deal with all sort of patient, and even the surgeons, everyone need to play a safe game. No one want to put their head in and create an issue. So if the patient is stable, you want to document your stuff, you need to have a CECT abdomen, but it's not a must. You have your patient who is bleeding, who is in shock, need to be treated. You can take the patient and without a CECT abdomen. It's not like the patient is having, we are resuscitating the patient is bleeding, and you wait for the CT machine to get free, because there will be some patient in the CT and you are waiting a half an hour, 1 hour to just wasting it for CT is not a pardonable stuff. Okay. Then CT angio is a very important investigation and investigation of choice or must for any patient with a retroperitoneal bleeding. You have a patient with because in the earlier time we used to tell that anybody who was suspecting or diagnosing a retroperitoneal bleeding, we don't touch the retroperitoneal, because retroperitoneum is like a closed compartment. So any, like blood vessels, they stop bleeding when you give compression. That is the best way to stop any bleeding, whether it is in the abdomen, in the thorax, or anywhere in the body. Even if you're cutting your aorta, you just give compression for 4 to 5 minutes, it is going to stop, because the clot will form and that will just seal off that area where it's bleeding from, and any bleeding will stop. But with the retroperitoneal bleeding, what we do is like, we have something called a retroperitoneum. Unless until you breach that, since it's a closed compartment, it will contain that bleeding and it will stop the bleeding. But with the advent of intervention radiology and CT angio, there are some cases where the patient will keep on bleeding, not exactly from the arteries, maybe from the veins or from some other small blood vessels. And with the help of the CT angio, you can just go and embolize that or stop that bleeding. So the patient doesn't lose a lot of blood. You don't have to open the patient and manually close that. So that is the help of the CT angio. So nowadays with the retroperitoneal bleeding, we do a lot of CT angios and you can literally stop the bleeding, and then you can save a lot of lives. And then next important thing which we do in a abdominal pelvic fracture is the cystourethropy and the IVU. Because you have to suspect a renal injury, a bladder injury, or a urethral injury. These three things are very, very important. Renal, many cases we don't intervene, but a bladder and urethral injury you cannot ignore. Because what is the problem with the urethral injury? Because I already told you in the previous slide, you have to put a catheter in. So what are the cases where you won't pass a catheter? When you're suspecting a urethral injury. Okay, how will you suspect that urethral injury? Yeah, you are exposing the patient, you want to put a catheter, you are exposing the penis over that area, and you see a drop of blood over there. Don't put a catheter. Okay, a drop of blood, because that indicates there may be a urethral injury. Until unless you rule out that there is a urethral injury, you will not put a catheter. Why we are stopping the people from putting a catheter in urethral injury? Male urethra, you know, it's having a very zigzag passage. It's not easy to pass a catheter in the male. In female, okay, it will go very easily. But with practice, even the male catheter restriction, anybody can do it. But when you're putting a catheter in a urethral injury, it will go in a false passage. Okay, that bleeds like it's a voracious bleeding, and you put a catheter, you see only blood is coming, no urine. Okay, you don't know whether it has gone into the bladder or it has gone somewhere else. So in these people, you have to, you don't be in a hurry to pass a catheter. You must rule out whether there is a urethral injury, and the choice, like the baby drain the urine is by doing a suprapubic catheterization. Okay, suprapubic, like we put the catheter directly into the urinary bladder and drain the urine. And these are some pictures of the pneumoperitoneum and the diaphragmatic injury. You can appreciate that. This. You can appreciate this right side. That is a pneumoperitoneum. The same, this which is seen on the left side, it is a common thing. You can have a stomach shadow. So this is not significant at all. You see only this shadow, don't think it is a pneumoperitoneum. That's the commonest mistake you do. So how will you know that it is the right side or left side? In X-rays, I don't know how many of you know how to fold the X-ray and read it. How will you know it's the right or left? One is like the X-ray, there are some protocols when they take the X-ray, they always mark it right. On the top of the X-ray or on the bottom of the X-ray, you can see there is written right. But if you are taking in a hurry, or you are doing a screening or just shooting in the emergency room, then you have to look at this cardiac shadow. Okay, the cardiac shadow is supposed to be in the left side in almost all the patient, unless until the patient has got a dextrocardia. And you can see the liver shadow on the right side. That is how you make out. So if you're seeing only the pneumoperitoneum on the left side, just ignore it. That may be a stomach shadow. But if you're seeing something like this on the right side, you have to suspect a pneumoperitoneum. That is air in the peritoneal cavity. And that is 100% indication for surgery. You have to open the patient and see where the air is coming from and close that. And here you can see the diaphragmatic injury. Here you are seeing a gastric bubble again, but what is the difference? You are seeing the diaphragm here. Ideally in a patient, the liver is supposed to be on the upper level and the left diaphragm is at the lower level. Okay, that is the situation in almost all the cases. Here you can see the right diaphragm is at lower level and the left is at a higher level. And you are seeing the gas shadow in the thorax. Okay, this is a case where you suspect a diaphragmatic injury. Diaphragmatic injury means there is an injured diaphragm and your abdominal content is going inside the thoracic cavity. Okay. These are two things you need to tackle at the earliest. No time for that. Then this are some CT pictures. You will come across. Here you can see a liver injury. This is a liver. And can you see this black color over here? That is a nice laceration of the liver. The liver is just cut over there. And here you can see the pancreas injury is a very, very rare stuff, pancreatic injuries. But you can see this is a pancreas, this coma-like structure, this thing. And it is just transected like this. And this is a splenic injury. You can see the liver nicely over there. This is spleen. This is your stomach. And can you appreciate this? And some blood over here. This is the hemoperitoneum. There is perisplenic blood. But this is a traumatic area where you can, because the spleen is supposed to be white when you're giving a contrast over there. But if you're seeing a black shadow inside the spleen, that is a blood. Okay. And this is the kidney. It's easy to make out. You have the right kidney over here, you have the left kidney over here, and you can see all this black stuff over there. Because when you give a contrast in the liver, in the spleen, or wherever it is, the contrast will go into the blood vessels, and that will all look white. And whatever is not enhancing, we call it as not enhancing. That is the black area, it's all blood. Okay, so these are things in the CT scan what we are looking for. Why I'm showing you this is we cannot always rely on the radiologist to give a good report because many times they are not available. And we ourselves have gone to the radiology or get the reports and see that my liver is injured, my spleen, because I'm doing a laparotomy, I should have a background idea what I'm looking at. Where I'm going to remove the spleen, I'm going to do whatever it is. Then coming to the nursing interventions, we already spoken about this, like established, because since last 2 days you are hearing all these things continuously must be knowing. Any trauma patient coming in, secure the airway, breathing, and then put 2 large bore catheters, IV fluid as ordered. You should be giving 1 to 2 liters, just flush it. And if you are suspecting a major abdominal trauma or a pelvic fracture, the blood product, the moment you put the cannula, you will take out the blood, send it for cross match, and keep the blood ready. And if that group is not available, you ask for O negative blood. And another important thing, antibiotics as ordered. You have to prevent the infection. It's like you are treating the patient and your patient has to go out also without any major infections. So antibiotic has to be given as per the protocols of the hospital. And then another important thing which you have to roll out is you have to tackle is a pain. Pain is very, very important because the patient will be screaming in pain. You cannot just rolling from here to there on the trolley, doing all the investigations and just ignore the pain. Okay. So the pain management is very important. You have to give some painkillers, and nowadays with all the blocks they give, all sorts of blocks are available, or you can just give some IV analgesics or some intramuscular products, and the patient should be comfortable. Okay, it's not like he's screaming in pain. He got some lacerated wound or some abdominal trauma, and they are very, very painful. When that can very traumatic thing. Okay, so take care of the pain. Then coming to the other tubes, I already told you a patient should be having a Rice tube and a catheter if possible. And if you're seeing some blood over there, don't touch the, don't even attempt to do a catheterization. Then the surgeon will tackle that. They will put a suprapubic catheter. Then coming to the next thing, that is the hemorrhagic shock, which you have to tackle when the patient is having an abdominal trauma. The hemorrhagic shock is the most common cause of death in trauma because you have an accident, patient is bleeding, you don't stop it, you don't resuscitate the patient, they will definitely die. That is the 50% of patient which we were talking about. That 30% patient which are coming to us, or the other 50%, 20%, we try to do something. We have to stop the bleeding and resuscitate, give blood, give fluid, whatever it is, and your patient is saved. It's like, okay, and that has to be done in a very systematic manner. You have to stop the bleeding. It's not like patient is bleeding from one and you resuscitate from the other. Like you have something called a grade 5 liver injury or a grade 4 or 5 splenic injury. The patient is bleeding continuously from there. You are giving fluid, you are giving blood. It's not good. You have to stop the bleeding and then resuscitate. So that will decrease, that will save the organ ischemia and the reperfusion. These are 2 things which you have to, which you will come across in the later stage because it's a fancy step. You taking the patient in, you're operating the patient, but why my patient is dying? These are the reasons. This is the organ ischemia which is suffered due to the injury and the delayed resuscitation. And there is something called a reperfusion injury. Like there is a period of ischemia and you are not giving the blood or the blood products, oxygen is not reaching there, and there is an ischemia over there and you are giving again blood after some time. and that causes a reperfusion injury, which is very bad, and that is the cause for the delayed or the other organ injuries and the patient going in MODS and death. Okay, coming to the class of hemorrhage shock, I hope you all know about it. It's been always talked about class 1, 2, 3, and 4. And then coming to the severity of the shock, there is something called a compensated and a decompensated hypovolemia. I hope it is also been discussed, but I'll just say compensated like 10 to 15% of blood loss. No one is bothered. The body itself will compensate that. You don't have to worry about much about it. There is no change in your heart rate. There is no change in your cardiac output, and the splankling, like you're losing blood from here, some other part of the body will compensate for that, and you won't even know that patient has got a blood loss. Will stop by itself. The next category is something which you have to you are supposed to take care of. That is more than 15% of blood loss. There the patient will come with the cold periphery, tachycardia, and wide arterial blood pressure, tachypnea, confusion, and all these things. And there is something called a decompensated. That is a lot of blood loss, so more than 40% of blood loss, where you get again hypertension, tachycardia, oliguria. Oliguria is how much urine you expect after you put a catheter. Anybody has any idea? You're passing a catheter in a trauma patient. How much urine you expect? You're monitoring the patient. Sometimes you put a catheter, you won't see any urine. Like if the patient is coming to you after half an hour, 1 hour, already patient in shock. So we put that urometer and keep on checking how much urine. So you might be wondering why they're asking that. No idea. It's around 0.5 to 1 ml per kg per hour. If you have a patient of 50 kg, you need at least a 20 ml per hour. That is a minimum we want. Anything below that is the kidney is not working or the patient is not perfused properly. Okay, so if you are not treating this hypovolemia or the shock, the patient will eventually go into SIRS, that is systemic inflammatory response syndrome will be activated. The patient will go into MODS. So once they go into MODS is multiple organ dysfunction syndrome. So once that MOD stage is setting in, then it is very difficult to bring them back. And then you should have the world-class ICU and all sort of interventions and bombarding them with everything. Then still it is difficult to bring the patient back once they go into the MOD stage. Okay, so what are the effects of hemorrhage? Hemorrhage is just not bleeding from somewhere. That has got a lot of effects in the body. So there can be acute renal shutdown, which we can monitor by checking the urine. It's a simple test, like because when you have a bleeding, but the body has got it's a very fantastic organ. Your body is very good. It compensates a lot of things. So when there is a bleeding and the patient is bleeding from somewhere, body knows that where all the blood has to go. Your heart has to be protected, your brain has to be protected, and your kidney has to be protected. So they divert the blood from some other areas to these major organs. That is why you're getting the cold clammy extremities. Your skin doesn't need so much of perfusion. So all the blood from there goes to the major circulation and the major organs. Okay. So when the blood is not reaching there or the oxygen is not reaching there, then the other cells get ischemic and you can get a renal shutdown. The kidney cells will start feeling the ischemia, and then you have a liver cell dysfunction. Your SGLT, SGOT, and the liver function they start altering, and there can be cardiac depression. Then there can be other hypoxic effects on your brain, and then something called a metabolic acidosis. Metabolic acidosis is because of hemostasis, and that's which I told you, that is something called a lactic acidosis. You have a lot of, because your oxygen is not reaching there and the lactic acid is being produced a lot. So that will give rise to acidosis. That is called a metabolic acidosis. So in the ABG, the first thing we see is the pH. What is the normal pH? 7.35 to 7.45. Anything below that is the acidosis. So if you are seeing a patient whose ABG is showing a lactic acid high and your pH is below 7.35, the patient is already in acidosis and you have to do something to reverse the acidosis. Okay. And then comes the GIT mucosal ischemia. It does something which is being ignored. But with the latest studies and all these things, the GIT mucosal ischemia has come up as a major cause of death, because I told you that GIT doesn't need a lot of blood when the patient is NBM and all that, because you need the blood to absorb the steps. But the latest study, they show that the GIT mucosal ischemia also is something which has to be avoided, because your gut has got a lot of flora. and you need some sort of blood, if there is an ischemia, your mucosa will get the bacteria which is not required, they will start replicating over there, and that again will go into systemic circulation, and that can give rise to sepsis. Okay, so GIT is the area from where you can get the sepsis. So GIT has to be working. That is the funda behind giving the early feeds. Okay, so the patient is having trauma or doing some surgery. This is the first thing we start, like early feeds, like your GIT has to be working, your bowel has to be working. So they will put a rice tube, or we put a feeding genostomy, or we put some sort of tube from somewhere, and we start feeding at the earliest. The moment the bowel start coming, we start feeding the patient. Okay, your bowel has to work. Then comes your sepsis, your interstitial edema, AV shunting in the lung. They are a very complicated step. I hope someone must have told you about this thing. AV shunting and ARDS is something another which is very irreversible and that can kill the patient. And then comes the MODS. Then how will you monitor the patient in shock? Already told you, ECG, pulse ox, all your fancy instruments will come in and we start monitoring the patient. And that comes to central venous pressure, CVP monitoring, and invasive blood pressure through your art lines. And you have to monitor the cardio output and base deficit and the serum lactate by doing serial ABGs, or by there are some machines which are coming. You can connect to the art lines and see all this. You can see the lactate levels in the base deficits. Then coming to the management per se. So you have identify the hemorrhage and control that. So most importantly, you resuscitate the patient. Along with that, you have to identify what is bleeding from and control it the earliest. And immediate resuscitation with the fluids in the blood. And imaging includes CT and FAST, we already told. And there's something called the damage control surgery. I'll come to that later. Okay. When will you do a laparotomy in abdominal trauma? Any patient with a sign of peritonitis, I already told you, the abdomen is guarded, and don't think no second thoughts. Take the patient in, open the abdomen, see where it is coming from. You have to close that whatever is the organ. Otherwise, the patient will die of peritonitis and the bowel injury. Then anybody with an uncontrolled shock or hemorrhage, you are giving fluids, you are giving blood. My patient is not getting revived. You're suspecting a solid organ injury. Because in solid organ injury, not all the cases we open up. Bowel injury, we have to open up, but in solid organ injury, not. There are a lot of guidelines and all that. You wait for that guidelines. Grade 1, 2, 3, we don't open. 4, 5 is conditions where we open. So you will be keeping the patient under observation and reassessing them all the time with solid organ injury. And your patient is not coming out of the shock and the hemorrhage. That is a condition. Although it is a grade 2 or 3, you have to open and control the bleeding. Okay. And all patients with the penetrating trauma need to explore the abdomen and see where it is, because maybe a small knife which is maybe, or some need, not exactly need, some sharp instrument is going in, and in the CT or USG they may tell you that there is no breach of peritoneum, but don't believe that reports. Probably it's a very small stuff which has gone in the bowel and causing a small hole in the bowel, or it may be causing a small hole in the major vessel or something like that. It will go unnoticed. So all penetrating trauma in the abdomen, you have to explore the patient and see whether what is injured, and if there is nothing, there is no problem, because the negative laparotomy is okay with the abdominal injury. Okay, so with the advent of laparoscopy, we are more at ease, because we are not suspecting a major injury. You just have to look in the abdomen and make sure there is no major bleeding or grade 4 or grade 5 injuries. You can put in a laparoscope and see also what is bleeding, or is there any peritoneal contamination, and like if you feel like opening, or if you are a good surgeon in laparoscopy, we can tackle it by laparoscopy. And any patient with an iatrogenic trauma, which I already discussed, like need to be opened up. They need a laparotomy or a laparoscopic intervention, and you have to clear that. It's not like I'm injuring the bowel, I'm doing a endoscopy or a laparoscopy surgery, I'm injuring the bowel, I'm just leaving it unnoticed, patient will die out. The surgery will go very smooth. Second or third day, they develop a peritonitis. That is unpardonable, and you are 100% chance of getting stewed in the court. Okay, so these are the indications for laparotomy. And for a laparotomy, whatever is injury in a trauma, a midline incision is preferred. Suppose you're getting a report of splenic injury. Splenic is in the left side of the abdomen. And if you're doing elective splenectomy, we put a subcostal incision of below the ribs and open it. But anybody with a trauma, you're opening, always a midline incision is preferred, because abdomen is, you all must have heard of this, a magic box. You open and then only you know what is happening inside. It's spontaneous clinic injury, and if you're seeing a pancreatic injury, then you can't just have all zigzag and crisscross incision in the abdomen. So almost always we open with a midline incision. And next is a bleeding control. Like when you open the abdomen, it will be just the blood gushing out or the fluid gushing out. So you suck it out and pack all the 4 quadrants. You have the liver, you have the spleen, you have the pelvis, and your kidneys. Mops of packs over there. And then each and every quadrant, like once you control the bleeding, then we start removing the packs from one quadrant and see what is bleeding from. You see that, control that. If you can suture it back, because in the liver, you cannot remove the liver. Spleen, almost all the cases you can take out the spleen, that's not a big issue, but liver, kidney and all these things and pancreas, they are not easy to remove, especially with a normal or an unexperienced surgeon. So you have to control it and keep the packs, control that. Like we remove the right hypochondral pack, then we remove the left hypochondral, then you remove the pelvis, then near the kidney, we remove each and every pack and then see and look for whatever is injured and damaged and do the surgery accordingly and come. Okay, and after the intraperitoneal injuries are controlled, like the peritoneum is with you, and then you look for the retroperitoneal and the pelvis. If there is a major, if there is not suspecting a major retroperitoneal hematoma, just leave it like that. Even the kidneys, you don't have to tackle it in an emergency situation. They all can be done later. The first and foremost is something called a damage control surgery. I'll be in the next slide. I'll tell that. You have to stop the bleeding, save your patient. And you can always have a second look and a second surgery and do the definitive surgeries later. Okay, and this is a damage control surgery. In the damage control surgery, the principles are control the hemorrhage with packing, because suppose you have a grade 4 or a 5 liver injury. Liver is a big organ, it can bleed from anywhere and everywhere. And you are not able to see, or it may be a deep injury, and you can just see that liver is cut and something gushing from inside, and you are not good enough to tackle the liver injury, because not everybody is a hepatobiliary surgeon, and liver is a very dangerous area to touch. You have all the major vessels, you have the IVC below that, and all the hepatic vessels and everything, so bleed like anything. So what we do is we just pack it. You can put a mop, you can put even a bed sheet inside that, you can put a gel form, so many things and everything. Just put your hand over there and resuscitate the patient, control the bleeding. And if it is getting stopped, well and good. Otherwise, what we do is we just leave the mop over there and with all the hemostatic agents over there, and just close the abdomen and come out. Let the patient be stable, and you can get all the help in the world for you. Like you can call somebody else, take the patient somewhere else if they are not good enough. And the person who is expertise in that, they can tackle the bleeding or remove that aerial segment of the liver later. Okay, so that is called a damage control surgery. So that will that will stop the bleeding, prevent the contamination with a temporary closure, and that will avoid the further injuries. Like you don't know how to tackle a liver injury, you just put suture, they will go keep on cutting through, and the patient will keep on bleeding. So in trauma, like the thing is like you have to do whatever you're doing, it should be done very, very fast. Stop it and then close it and come out. Quick in and quick out. Okay. And the patient will be resuscitated, around in the ICU, stabilize the patient, and then you can re-explore the patient and repair it at a later stage. Not a very later stage, maybe in 24 to 48 hours. Then the indications for damage control is one is hemodynamic instability. Your patient is having a BP of 80, 40, 60. These are things we see, and you keep on controlling something, suturing something is not okay. You just pack it, come out, bring the BP up, stabilize the patient, save them from all the acidosis and everything, and then do the surgery later. And then the next important thing is the coagulopathy. Coagulopathy is like, you must have heard of this, that's a DIC, disseminated intravascular coagulation. You are transfusing the patient with a lot of blood, massive blood transfusion. They will naturally go into coagulopathy. Anybody who is in coagulopathy, you keep on operating, they will start bleeding from here and you can't do anything. So the coagulopathy you have to control first and then go and operate the patient. Then comes the severe metabolic acidosis. I already told you, pH anything more than less than 7.35 is acidosis. Severe acidosis is less than 7.2 or base visitor more than 8. Then the next thing to rule out or you have to tackle is the hypothermia. What is hypothermia? Your body getting cold. It's very, very important because nowadays in the OT you must be seeing like not. Most of the OTs you have something called a warm up. The moment they start inducing the patient, anesthesia will ask for a warm up. You have to put a sheet on the patient and the patient will be warm all the time when you do the surgery. Because the insensible blood loss and the fluids which you are giving in, they take away a lot of temperature from your body, and OT is always cool. So the hypothermia and the injury related to that is very, very important. So you have to prevent the hypothermia and the injury due to that. Especially this happens in a long duration surgery. You are taking a patient in and the surgery is going for 3 hours, 4 hours, 5 hours. The surgeon will be keeping on operating. They will not even realize that. But after 5 or 6 hours, the patient will be in hypothermic state. Okay. And prohibitive operator triple injury more than 30 minutes, anything which is going above 1.5 to 2 hours, just stop it over there. You have to finish your surgery in around 2 hours time. Okay, and there is something called a high energy blunt thoracic trauma, like heavy vehicle, the abdomen will be like shattered like anything. You cannot even see the abdominal wall. So they are the open abdomen or the open book fractures and all that. And multiple penetrating torso injuries, multiple visceral injuries, major vascular trauma, and multiple injury across the body cavity. Not only this thing, you have another fracture femur, bilateral fracture femur, some crush injury on the leg. So patient bleeding from everywhere. So you can't just play with the abdomen all the time. Okay, so these are the areas where we institute the damage control or you follow the damage control surgery and massive transfusion requirements. And presence of injury better treated by non-surgical agents like intervention radiology and embolizer vessels. So we can do that in the, these are the indications for the damage. Then the approach nowadays is earlier we used to do, take the patient from the emergency to the OT, the patient may die or may not die. Now, take from the emergency to the OT, do the damage control surgery, they will be shifted to the ICU. You can always have a second look in the OR again within 24 to 40 hours. They will again come back to ICU. They are much stable conditions, stabilized, come back to the ICU and the patient will walk out of the ICU. We hope so. Okay. Then a word on the massive blood transfusion. I hope people are, I'm the last speaker. So they already must have discussed all these things. So what is massive blood transfusion? When you're asking for a lot of blood and blood. So you cannot just keep on asking for the blood. So when you're expecting a massive blood transfusion, patient in shock. I'm sorry about that spelling mistake. So you have there is something called a massive transfusion protocol which has to be evoked when you start the blood only. So transfusion more than 10 RBCs, which approximate the total blood volume of the body. How much is the total blood volume? Around 4.5 to 5 to 6 liters. So here, expecting more than 10. One blood RBC contain how much blood? One packet? 300. So 10 matlab, it's around 350 ml. It's around 3.5 liters you are transfusing. So that is a massive blood transfusion. In an adult, I'm talking about the adult patient, not the pediatric. Okay. And transfusion of more than 4 RBC unit in 1 hour with anticipation of continued need for blood product support and replacement of more than 50% in 3 hours and transfusion support to loss of blood more than 150 hours. Okay, so these are the things which you are supposed to follow. I think already mentioned all these things. This is in nutshell. So initiate the standard protocol, administer oxygen as needed. Cardiac monitoring, secure to a large bore IV line, put all your tubes and order laboratory investigations. And then if there is an indication for laparotomy, shift the patient to the OT and the rest thing will be done. So that's about it.
Thank you so much, ma'am. I request Ms. Poonam Rani, tutor MGM New Bombay College of Nursing, to appreciate her with the certificate. So now we'll be dispersing for lunch break. Kindly ensure to come back within half an hour for the paper and poster presentations. Those who are presenting paper, kindly be ready with your presentations.